Good morning, everyone. A very warm welcome to this year's first webcast on art and science of prostate resection, being held under the aegis of Indian School of Urology, USI. And I'm very glad to welcome the President, USA, Dr. Sanjay Kulkarni, and the moderators for this webcast, Dr. N.P. Gupta, Dr. Deepak Kirpikar, and Dr. Keshav. And very warm welcome to the team of ANU who will be demonstrating these procedures. We all know that the techniques of prostate resection is tailored to the patient factor as well as the anatomy of the prostate. And we also know that this technique vary amongst ourselves. But to learn, we have kept this webcast, which will impart knowledge about the art, which we will see what the masters perform, and the science, which the masters will be talking when they are performing, as well as the quality comments made by our moderators from their experience. With again a warm welcome, I'll hand over to Dr. Sujata to carry on the proceedings further. Madam, over to you.
Yes, sir. Good morning, everyone. And again, I have warm welcome to everyone. And we have Dr. Malika Arjun today, and we are really excited to go ahead. And without much of, I would request Sanjay Kulkarni, sir, who is in a workshop. I can see him scrubbed up to please say a few words. And if Prashant is there, I'll request him also. So Sanjay Kulkarni, sir, can you please say a few words about? I think he's busy.
I'll call ma'am. I'll just call him.
Yeah. Is Prashant there, please?
Ma'am, Prashant is just finished. He's in Mumbai. There's a Mumbai marathon. He just finished and he is leaving to hotel. He told if he gets, he will join on phone. Yeah.
Okay, sir. So we'll wait
I'll
for
just,
Kulkarni.
yeah, just 1 minute.
For Sanjay joins, I thank USI and ISU for giving us this opportunity to demonstrate the art and science of TURP. In fact, the whole thing was of art and science of enucleation, which was the previous talk of ours. But anyway, now it is art and science of TURP, which appears to be the bread and butter of it. Thank you very much, and thank Taif also to join us today for this demonstration of a TUR. We are trying to demonstrate 3 or a maximum of 4 cases in the next 3 hours duration. Thank you very much for this opportunity given to us, Sujata.
Yes, sir. Thank you very much. And we would like you to introduce your team in the meanwhile, sir. Who all will be there, sir?
Well, I'll be operating the first case of TURP. The next case will be, we alternate. We both are operating. Dr. Baltej will be more. I know. So we are the 2 operating surgeons for today.
Sir, you would be giving a brief talk about preserving continence in TURP.
Yes, I'll be.
And start, right?
No, it's in the middle. It's in the middle. We'll see the progress of the thing, and in the middle we'll start. I think somebody can take over the instrumentation initially for the first 10 minutes, and then we can go ahead with the live session immediately.
Ma'am, Dr. Malik, Dr. Sanjay is joining. He told just give a few seconds. He'll be joining. I think we'll be going with the webcast because Arvind is in the Sogar. So he told around 11:30 he'll be coming for the instrument session. Yeah, we'll straight away go with the case presentation and then we can go.
You can go ahead with the surgery?
Yes, sir.
Okay, yes. Okay. Then I think we'll go with the case presentation. I'll scrub myself. Thank you very much. Case presentation. Sorry.
Is Dr. Sanjay, sir? Dr. Sanjay?
Sir, you have to unmute yourself, sir.
Hello.
Yeah.
Yes, sir, we can
Yeah.
hear you.
Yeah. Please, sir, go ahead.
I'm sorry for the delay. There was a problem with the internet connection in the theater. We have a urethroplasty workshop going on. In 2 days, we are going to perform 10 cases. So today is an important day for USI. ISU is conducting this live surgery workshop. And the most important part is Dr. Mallikarjun, my favorite surgeon, because I have learned a lot from him in laparoscopy and TURP. He's going to demonstrate 2 cases, and we have a fantastic chairman, Dr. L.P. Gupta, Dr. Kirpekar, and Dr. Keshav Murthy. So I welcome all of you to this USI, SIU, USI ISU program today for BPH. Welcome.
Thank you, sir. And sir, shall we proceed with the case?
Yeah.
We'll pass
Yeah,
over
yeah.
the mic to Mallikarjun, sir. Yeah.
Yeah.
And I welcome also all the moderators, Narmada Gupta, sir, Kirpekar, sir, and Dr. Keshav Murthy. And I hand over the session to you, sir. Yeah, we can see the slides, but they are not in the center. AINU team, can you please project the slides so that they are properly centered? Sir, should I call Mallikarjun, sir? Chawla, sir?
Call, ma'am. I'll call you soon.
Chalo, you're able to hear me?
Yes,
Yeah.
sir, we can hear you. The slides are little off-centered, sir.
Okay, I think they are adjusting. Is it okay,
Okay.
now?
It's fine, fine. You can go ahead.
We can start, sir. We can start.
Okay, I'm just showing the instrumentation, nothing more than that. Anyway, most of the time in a smaller gland for juniors purposes, I'm explaining. What you require is a meatal calibrator to understand the most common area where the urethra is going to be narrow is going to be meatus and submeatus. So before we start off, have a meter calibration to understand how much is the urethral diameter at that point. In case if it is not adequate enough, in which case we may need to do a meatotomy initially itself rather than forcible dilatation of the meatus, which ends up in a stricture at a later point of time. So that's a meatal calibrator, a cystoscope, which is mostly necessary. And
Mali, you're showing the instruments. We are
yes,
seeing the slides.
now.
Yeah, now it's
no,
all
no,
right.
no. What I'm using it, I'm just saying it now. It's exactly no.
All this time the slides were on. Now we are able to see these.
Okay. Mode it now. Okay, no. Fine. You got the case material, right? That's fine.
Yeah.
So now you're getting the external picture of the instruments what we are trying to use now, and I'm showing the instruments and the layout of the table. One is a meatal calibrator. I don't say it is a dilator. It is a calibrator to understand the meatus, the size of the meatus. Most of the time, the narrowing happens on the submeatal area is the most narrow area, in which case forcible dilatation will present in a submeatal stricture at a later point of time. So have a calibration. If it is less, go ahead with cutting the meatus or doing a meatotomy rather than having a stricture at a later point of time. That's number one. Number two is going to be a cystoscope, the usual cystoscope with a 0-degree or a 30-degree lens out of your choice. And because this gland is only a 45 cc gland on ultrasound, so we are using only a 24 sheath, which is not a continuous irrigation sheath, a 24 sheath, a Olympus 24 sheath is being used, and a visual obturator, which is already set in place with this already. That's number one. That's the thing. And a passive instrumentation, passive working element, which has passive means the thumb moves, thumb moving. Active means the finger moving thing. Finger moving is one of the favorites for many surgeons, but I think most of the people have shifted to a thumb movement, which is very, very essential, which is commonly used. These are 26 outer sheath. In case if there is a large gland, we think about a continuous irrigation, in which case we'll be using this sheath over onto this. And we are using a bipolar TURP. So we have a bipolar cable and a dilator set. Dilatation of the urethra is not dilatation most of the time. Calibrating the urethra, which happens in majority of the cases. In case, first of all, you do a cystoscopy. If there is any slight narrowings, which we cannot call it as a stricture, you may need to calibrate with a dilator to make it a little open and pass the resectoscope after adequate lubrication. And the rest of the things is a myototomy for scissors and extra loops what are necessary, and xylocaine jelly in plenty, and a saline and a 20 cc syringe for inflating the bulb, and an helix evacuator of your choice. This is not actually the helix evacuator. It's a modification of the helix evacuator, which has become a absolute hit, wherein you just have a collection of the chips inside the evacuator after the resection is concerned. So this is the equipment what we require. And anyway, this is an excess. Yeah, go ahead, sir.
Yeah, I don't see a Otis urethrotom on your trolley. Do you use it or you don't use it at all?
Otis urethrotom, we don't routinely use it, sir. It's not been my habit to do a Otis urethrotom in the last 30 years. No, not regular. No, absolutely not. Yeah. If at all, if there is a definite stricture, we do an optical erythrotomy with a Saxe optical. Optical erythrotomy with a Saxe, but not a Otis urethrotom as a routine, sir. No, sir.
Okay.
So this is a lithotomy position, not an extended lithotomy like a stirrups. With I think it has been changed. 20 years ago, what we had that was a gynec stirrups, but it has been changed with a definite stirrups, which can give you a 45-degree angulation of the hip, and that is most comfortable for the patient. Majority of the times we keep the patient supine, but sometimes I keep the head end a little low, so that my idea is to keep my resectoscope absolutely parallel to the floor in a resting position. Sometimes in a deep median lobe, the resectoscope will be facing upwards, in which case I'll get the head end down so that it comes as parallel, so that our working ergonomics is well maintained. So at present, I'm going to start my procedure.
But Mali, why do you want to use a 24 only? Why don't you use a 26 itself?
I really don't want to use in a smaller gland. I don't think a continuous resectoscope with a 26 size of any use. Basically, I think a 24 with the intermittent emptying of the bladder is good enough in these patients.
But don't you think that the continuous flow will give you a better vision, and your resection will be much faster because you'll have to empty in the intermittent?
No. What you said technically, scientifically, it is true. But in fact, why I don't use it is only because of saving the urethra. We all accept that Indian urethras are not as wide. Sometimes you get a beautiful, nice wide urethra, but sometimes you will not be able to have such a wide urethra. So that's the reason why I would prefer to do with a smaller resectoscope. In fact, we have shifted to a mini hole-ups, etc., wherein we are using a 22 sheets for continuous sheets. Probably they are ideal things for future, because we all at the end of this experience, we started realizing that it's an instrumentation, and the size of the instrumentation does have a role in the incidence of stricture in the postoperative period. I don't say I can have a scientific evidence for that, but we do. At one point of time, you still remember, where we were using a 26-sized catheters after a TURP 35 years ago. Then we came to 24. Then we came to 22. Now we are using only a 20 French catheters, three-way catheters after TURP. So we all started believing the instrumentation size or a catheter size does have a role. Not only the size of the urethra and the nature of the urethra does have a role in the postoperative stricture formation. I need your comments on that.
No, yeah, I agree. Mallikarjun, can I make comment, please?
Sir, please, go ahead, sir. It's all.
Yeah, Mallikarjun, I agree with you what you all have said, but let me give you our experience, how we have learned from Dr. Mansingh, he will always like to do a cystoscopy. And it takes only 2-3 minutes extra. You can do a cystoscopy, you know about the urethra, you know about any intravesical pathology, and about the prostate evaluation also can be done at the same time. And regarding BHS, I agree with you that if there is any doubt about BHS stenosis, our routine practice is to use the Otis urethrotomy. And regarding the size, if urethra caliber is very good, like what you have shown in this case, there's no harm in using 26.
Right on.
It will be a continuous suction irrigation, which has been accepted all over the world. I don't think so. Any persons are doing now interrupted, as you are saying that intravesical pressure will go up and all that kind of things. So I think so. This may be a different approach, but the principles are same.
Sir,
We have slender receptoscopes which are there, but the disadvantage is that the size of the chips which you take are smaller and the resection takes a longer time with the slender resectoscopes.
yes, definitely.
And
So
apart
I'm
from the
doing a
size of the
cystoscopy.
instrument,
I'm doing a cystoscopy. Just you're getting an endoscopic picture now?
yes.
Can you make a big view? Yeah, fine.
Okay. So I've done a cystoscopy. The anterior urethra is normal, pendulous urethra is normal. I came to the sphincter area, and this is the verumentanum, and that is an enlarged gland, and that's a median lobe which is existing there. And I've entered into the bladder. The bladder, first thing I see for any presence of any stones. I don't see any stone. There is some small calculi like things seen, and there is you identify the ureteric orifice, anatomy of the ureteric orifice. So I can see the left ureteric orifice. I can see a right ureteric orifice without any trouble across the median lobe. So I can feel a little more confident about my resection. And I see the bladder. Look for any bladder tumors anywhere. If there are anterior wall of the bladder and tuberculations inside the bladder. So a cystoscopy, a good cystoscopy is necessary before any resection starting is concerned. Don't believe on ultrasound alone and think that everything is fair and good inside the bladder. You may miss many things happening inside the bladder. And that is this is the verumentanum. This is the actual perineal membrane, perineal diaphragm area, which comes as a ring, and which we always say the location of the external sphincter. And that's a bulb, which is a little, that is a bulbar area. So we always see that we identify the sphincter with this point, but the sphincter extends right from the bladder neck down to the mid-bulbar area. So the most length of the urethra that need to be maintained is between the verumentanum and up to this point. This length of the urethra will determine the continence and the postoperative incidence of stress incontinence in these patients. So having done the cystoscopy, I'll take out the cystoscope and pass my resectoscope, that too under vision with a visual obturator again. Comments, sir? You can go ahead with the comments, sir.
So I think so, as you said, cystoscopy is necessary before starting the resection. That should be the message to all.
Yes, sir.
Absolutely.
That's absolutely
correct.
Once upon a time, if you remember, Gupta sir, 30 years ago, every patient of before TURP used to come for a minor OT and used to be calibrated because we were missing stricture urethra and we were taking the patients for TURP. No. And surprisingly, we used to have a stricture on the table. So the same thing, instead of a preoperative calibration, we are doing a preoperative or peroperative cystoscopy to see about a stricture inside, which we should not be missing when we do a resection. Am I right, sir?
Yeah, I agree with you. We normally put a Foley's catheter, 18 French, in OPD just to check that the urethra is normal or not.
Normal, sir.
But things have changed. We have now RGMC if you have a doubt, or you can do uroflowmetry. And if you are seeing an uroflowmetry that there is a box type of pattern, a 7 or 8, then you suspect in your mind there will be stricture also.
Perfect, sir. At once upon a time, there was nothing like RGU was a rarity, which was not routinely done, and uroflowmetry was not available at that time. Urethral calibration was a thing which was taken into consideration to know whether there is a stricture or avoiding a stricture. Right. So, like it.
Can you focus your Endovision camera, because maybe because of magnification
This is
it
a
is not
huge,
that.
this is a 4K camera, sir. 4K, that's the
Okay.
reason why the size will be very large and it is little, sometimes looks bigger
Now it's
also.
okay. It's better. It's
It's
better.
okay, sir. Yeah, I focused
Yeah.
it.
Yeah.
I focused it. So we look at resection. What I was talking about was head and down a little, because for a beginner's sake, you see, everybody, the resectionists who are experienced, they have their modalities of doing a resection. I always tell about for all the rest of the people that whenever you start resecting, have these loops of these things not hanging on to you. The first thing that has to go is going to be the irrigation tube, which is not going to be moving at any point of time. So that has to come onto the table first. The next come is going to be, the heaviest one is going to be the light cord, which comes later. And the rest of the two, which are going to be mobile, which will come out and in whenever you are trying to empty, has to be a little wider and possibly little having a little overhanging. These two things don't really require a big overhanging. I see many people having a light cord cable coming and hanging here, and it's putting a lot of weight onto your hand. So that's an ergonomically not an ideal position to work with. And second thing is, I want this resectoscope whenever I am putting in a resting position. If this is the way it is seen, I don't want that. I want that thing to be heading down a little, so that it becomes more parallel as I work with, and that will be more ergonomical. So having done this, it's the anatomy of the prostate which determines what sort of a resection you do. Let us not talk about how to resect the lateral lobes, which will become of varied natures like Nesbitt or a Burns technique. But resection of a median lobe is standardized. I don't think there is any difference of opinion regarding the resection of the median lobe is concerned. If there is a median lobe which is smaller like this, in which case direct resection of the median lobe is good enough. But when there is a median lobe which is very large and moves into the bladder, it is always better to resect on either side of the median lobe, identify the vessel, and then fulgurate the vessel, and then resect the median lobe, which becomes avascular. So there are two ways of prostatic resection. One is going on resecting and trying to establish a hemostasis. The second one is controlling the vasculature and then resecting it. So one becomes resection and hemostasis at the same period of time, which is a standard Burns technique wherein you go on resecting and go on fulgurating. Whereas Nesbitt way of doing it is take care of the vessels first and then resect. It becomes an avascular thing. So these are the two ways of doing a technique. But I still say for a beginner, it's always better to do a Burns, because getting to the capsule initially, if you end up in a problem into the capsule, you start having a problem right from beginning itself. So Burns technique is possibly the best for beginners. I have a little modification of the Nesbitt, which I'll show as I go ahead. And then, shall I start resecting, sir?
Mali, there are some questions in the chat
Yes,
box.
go ahead, sir. Go ahead.
When do you do pre-op urodynamic study for patients when you're taking up for prostate surgery?
Patients with a chronic urinary retention, patients who came without not an acute or chronic urinary retention, patients with voiding symptoms with a more than 15 to 20 years of diabetes mellitus, we always do a urodynamic study. I don't say that I will negate a TUR or a HOLEP or in a patient with a low voiding pressures. No. But I would certainly know that the chance of recovery, how it will be, I can predict. So this has been our protocol to do a urodynamics in these two scenarios.
Apart from three things what you have said, one more, the post-void residual urine. There's a debate in the literature between 200, 250 or 300. So if there is a PVR more than 200, it is better to do urodynamic. And what Malika has said is right. You can tell the patient, you counseling, that after the TURP, whether he will be able to void or not, and if he may also need some medical therapy after that, if required.
Right, sir. I'll start resecting the median lobe. Two issues whenever you start resecting the median lobe. Don't resect the median lobe when the bladder is empty, because the dome can come towards this area and you may injure the dome. So keep the bladder half full whenever you start resecting onto the median lobe. That's a mandatory thing. So that's one thing which I always advise. Second thing is, I was telling about two ways of doing resection of median lobe. One is directly going ahead and cutting the lobe. The other one is going to be controlling controlling the bleeder. So go to the portion where the bleeder comes on either side. Control the bleeder. 1 minute. Let me focus. Yes. Yes. So that's a bladder neck fibers, which is you already seeing. So control the bleeder directly here. That's a control of the bleeder, and then start resecting the medial lobe, which becomes avascular. So that's an actual way to be done whenever there is a large median lobe. So how much you need to cut? You go on cutting till you see a raw bladder neck fibers. That's a raw bladder neck fibers, and you be careful that you're not going extensively onto the trigone. So these are the vessels which supply the median lobe. So making that makes the median lobe a little less vascular. So there are two ways of resecting the median lobe, what I was been talking about. So increasing the groove and deepening the groove, that will show up the bladder neck. And people have a tendency to make this flat by resecting it. I would say resist that. I don't think resecting the bladder neck is of any use, absolutely any use. They have a tendency to keep it flat. It is not needed. It's absolutely not needed to keep the bladder neck flat, bladder area or the floor of the prostatic fossa flat. It is not needed. So I don't do that. So I just see the bladder neck and stop resecting there. I've seen the bladder neck there already, and I stop resecting there, and I control the blood vasculature to the median lobe now. And now I start resecting the median lobe, which has become avascular. Why we need to resect the median lobe? You need a space for the saline, which is getting irrigating into the bladder, to move into the bladder. For that, you require a median lobe to be resected or a floor of the prostate to be resected, so that there is a free flow of the saline going into the bladder. So this is a resection of the median lobe, which is almost complete. So this is a Veru. That's a prostate, and you see the median lobe, which is completely resected, and the bladder neck fibers, which is exposed. So that is the resection of the median lobe. Now, after that, and you are able to see, this is almost the plane of the capsule. You see this sort of a picture or a corpora amalacia, or this sort of a cyst, appearance of this cyst between the adenoma and the peripheral zone. That is the thing. So completion of the median lobe. Your comments, sir. I'll empty.
What are your settings, like?
Sir, this is an automatic setting. They have a once you put a loop, automatically the setting comes into picture, sir. So it's a bipolar automated settings by the company. So we don't really manipulate it at all.
But what does it show on the machine? You're cutting at 240, 200?
200 to 120. 200 to 120, sir. This is the
Okay.
typical.
Okay.
Yeah, that is 200
can I
cutting and
make comment?
120 coagulation.
I have the installed bipolar. They have got the setting 1 to 5 in coagulation, 1 to 5 in cutting. So in prostate, we keep 4 or 5, and whereas in bladder tumor, we keep 3 and 4. So that is the way you can adjust your settings. And so that is our practice. So I thought I'll add that storage have also a bipolar, and that I'm routinely using for many years.
So having done the median
Only
lobe
there are some
completed.
questions.
Yes, sir.
Do you ask your anesthetist to lower the blood pressure?
I don't for routine cases, possibly for a case which is around 150 or 170 grams, in which case I may think about asking them to do a mild hypotensive anesthesia for some period of time. And once I start coagulating towards the peripheral part, I'll ask them to stop that anesthesia so that hypotensive, so that I can do a hemostasis. After that, is not when it is not there.
So this patient's blood pressure is normal now.
No, this patient's blood pressure is around 128 by 72. The way you are looking at the bleeding.
The other question is that what loops do you use? Do you use the new ones or the old ones which are thin? What do you prefer? Thin loops or loops which are not?
See, the question is that sort of a discussion happens between a monopolar and a bipolar. We should understand that in a bipolar, it is not the loop which cuts. It is a corona which is created. Like if I am cutting the tissue, it is a corona which is created around the loop, which is the thing cutting. So whether it is a thin loop or a thick loop, it makes no difference at all. In a monopolar, it makes a difference, because in a thin loop, the delivery of energy is very high in a monopolar, so it cuts very easily, very sharply. Whereas in a thick loop, it doesn't happen, so you require a little more energy in a monopolar. But in a bipolar, that sort of a thing doesn't happen. In bipolar, there are thicker loops. I'll show you in the next case. There are wide, thick loops which require a little more energy, but they are basically for hemostatic effect. But the cutting nature of the loop doesn't change with the thickness alone. This loop, which is a standard loop of a bipolar, has got a fixed energy which is being delivered and the corona which is being formed. That's all. So the corona, which is the thing which cuts. And second thing is, as the coagulation happens, people have a tendency to coagulate and move like this. I don't think that is the correct one. We unnecessarily do too much of coagulation of a normal tissue, which is not necessary. Pointed coagulation, identify the bleeder, and pointed coagulation. That is the way to go about in any prostate. We have a tendency of rubbing the thing continuously. I'll do a Barnes technique of resection on one lobe and other sort of a resection on the other lobe. Once you reach the bladder neck, this is the bladder neck fibers. Don't be overzealous in resecting in the floor of the prostate, because this you can do it at the end. Let there be some amount of prostatic tissue stuck to the floor. We don't need to resect it completely at this point of time. So you leave a little amount of tissue onto the prostate and do all that resection as a toileting at the end of the procedure. So that is a better way to do it. So Barnes procedure moves from floor towards the lateral aspect. So from floor towards the lateral aspect. That's a Barnes. So you have done something in the floor. You do one and start going up towards the top. Okay. Again, you come from top and come to the bottom. This is a typical Barnes way of doing it, but it starts from the floor and to the lateral aspect. So this way of doing it, the advantage is you will not be reaching the capsule very early. You will be resecting any adequate amount of the gland before you before you reach the capsule. So getting into the trouble initially itself is going to be very uncommon in Barnes technique. So that is safe. This is what was devised when it started. So you start resecting in the below, next one, and next one. I give you one more technique. Whenever you start resecting it, don't use the whole loop to resect. Have, like, let me fulgurate this and then show you how. Okay, you have done one resection here. Keep half loop to cut the tissue, half loop to be seen. This gives you the correct way to know how much depth of tissue you are cutting. The same way I'm doing it. Half loop inside, half loop outside. Half loop inside, half loop outside. You very well know how much is the depth at which the loop is moving. That gives you an advantage and an understanding how much is going to be cut or how much is being resected. So you got that point? I think possibly somebody can comment on that.
Yeah. See, Malli, show them how you do this extended cut. That means you take the
Yes.
cut, you pull this
There are
resector scope and it becomes an extended cut so that you can resect. And there is a difference. Is there a difference between resection in the monopolar and bipolar? I mean, this speed of resection.
The second point. So first coming to the point of how do you cut the prostate? So there are 3 to 4 ways of cutting the prostate. Suppose whenever you start the procedure, you keep your loop, you keep your resectoscope at the verubantanum and see the measurement of the length of the prostate. So you extend the loop, which extends around 2.5 centimeters, and you keep it. So my prostate is this prostate is more than 2.5 centimeters length. So in one cut, I can't take out the whole prostate, and that is not advisable also. So either you divide this prostate into 3 or 2 steps. One is I'll take out from here till here, around the first 2/3, and the next 1/3 I'll take it at the end of that is apex, and that area will be taken after this is complete. So that's how the resection is done. So I have done a resection of this area. This is the way to cut. You keep your resectoscope fixed and you are moving only your thumb and your left hand. If you see my left hand, it is the passive element is going to be right hand. Right hand has got only one movement. Actual boating and the loop movement is dictated by left hand. The left hand will always tell how the loop is going to be moved in the tissue. Boat shape is coming because of the left hand movement, not the right hand movement. So never try to do this right hand and cutting and then both shade movement by right hand, it's going to be detrimental. So you need to have an adapt to a procedure wherein both your hands are working. I would say the active hand is going to be left hand and the passive hand is going to be the right hand. Right hand has got only one movement, that is inside outside of the loop. The left hand is the thing which determines the movement of the loop inside and the depth of the loop inside the tissue. So this is the first resection element between the bladder neck to the mid of the prostate or the 2/3 of the prostate. And the next cut is going to be between this and the apex. So this is apex or the last 2/3 of the last 1/3 of the prostate, which will be resected in the next loop. So that is one way of resecting the prostate. The extended loop is to be tried not by beginners, by only people who are experienced, who have done 200, 300 resections, wherein they have a good control on their hands. Their control on the hand should be perfectly good, so that say this, if this is the verumontanum, I'm keeping it here. I'll start my loop there. I start resecting there. I come out and come out and come up to this point. And I move my resectoscope behind. From here, I'll move my resectoscope behind and my left hand is moving the resectoscope away. So that is an extended length cut wherein you will get a more than 2 centimeter or a 2.5 centimeter chip size. But I don't think that is a routine thing. What is necessary? That is necessary only when you attempt large, big glands. So when an extended loop is there, you're going to cut it like this and go move around and come back and see that your whole prostatic tissue comes as one chip from bladder neck area till the verumontanum. So I don't think that sort of a resection is not necessary for most of the smaller gland. That sort of a thing possibly is necessary only for a big gland. So when I look at the Barnes technique, what I did was I resected the gland between the bladder neck, midway or a little less, more than the midway of the prostate. And now I'm resecting the gland from that midway towards the apex of the prostate. So when you look at apex, this is the verumontanum. So I have my marking saying that, okay, this is the limit at which I need to stop. And this limit will go a little proximal in the 12 o'clock position because the sphincter is a little proximal in 12 o'clock. So this is my markings at which the resection should stop. And the sphincter from this area down to this area should be intact. So this is about an extended length.
There's a question when you're addressing this. What do you do when the tissue extends? There is some glands where the tissue extends beyond the veru.
Yes, we have the next case, which is 150 grams. You'll be able to see how Taif does it. And that point will be well explained in the gland. That's the reason why I kept that size of the gland there. Okay. And that's number one. And the second point which is being said was what is the difference between monopolar and bipolar? If you see this, if in a bipolar, you activate the loop and cut the tissue. Whereas in a monopolar, you tag the tissue and start cutting the tissue. That is the difference. You see, in a monopolar, there is some amount of physical energy by the loop which will be involved during the cutting of the tissue. Whereas in a bipolar, it is not needed. What you require is a corona which is already created, which will cut through the tissue, and the loop will move through the tissue as a butter, as it is moving through the butter. So that is the difference between monopolar and bipolar. What happens when the people will switch from monopolar to bipolar? What happens initially is they start losing the loops because they tend to cut with the loop, thinking that it is the loop which is cutting. No, they should not be doing that. So many times, even when we started the bipolar, we used to go lose a loop every case because we start cutting with the loop, because that's what happens in monopolar, that you start cutting with the active loop and there is a physical energy involved. So that needs to be avoided whenever you are doing with a bipolar.
But Malik, for bipolar, don't you think your loop has to be a little slower than the way you are using it?
Yeah, I am doing it my slowest way, sir. I'm sorry to say that. But yes, your point is absolutely true. In fact, the advantage of a bipolar is when you do it slowly. If you do it fast, the actual hemostatic effect of the bipolar is lost. So correct. I tell you, absolutely true, sir. You are absolutely true. When you do it very slowly, the hemostatic effect will be very, very, very good. So I'll show you one when I'm doing it. If I start cutting this tissue very, very slowly, the hemostatic effect will be very, 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 very good. That's absolutely true. No doubt, sir. very slowly, the hemostatic effect will be very nice. You don't need to go back and fulgurate the bleeders there again. I'm doing it very slowly. You can see the difference completely.
Absolutely correct. And you are actually speaking, coagulating the bleeders again and again because you are not using the Iglesias equipment.
Yes.
And every time you empty it, you've got to go back and coagulate some more bleeders.
Yes.
You would still not want to put on a 26 sheath on it and make it into a continuous irrigation?
No, sir. Basically, I tell you, see, so I don't know. You may be true, but I always resist to use a bigger size sheath unless warranted. Like next case, possibly it's a huge gland, so we think about putting a bigger sheath and Iglesias. But practically speaking, this resection will not take much time. So I may empty it 3-4 times because demonstration sake, I'm taking it a little more time. But otherwise, any of these size glands, we don't really put a continuous sheath at all, sir. Just for saving the urethra.
Mali, there's a question. What is your opinion regarding coagulation, comparing bipolar and monopolar?
I would say
bipolar is much better.
Bipolar, the coagulation, this thing is much better. Unfortunately, the problem comes in monopolar is the tendency of the amount of heat generated onto the tissue is much higher. So the necrotic effect of tissue of a monopolar resection is going to be high. You see, experts, especially people who have done monopolar for years, they have a fantastic control, like pointed coagulation, leave the rest of the things. Pointed coagulation, leave rest of the things. That sort of a thing, if you do, even monopolar is essential. I don't think the results will be anyway different between bipolar and monopolar. It is a way to cut and way to create is the only thing which matters. That's all. But coagulation definitely is much better with bipolar, sir. So this is what I was looking at. Was I showed how the bands technique started. It starts with the floor and goes towards the sides and comes up towards and you come from above bound downwards and again from below upwards till you reach the capsule. That is the idea. So suppose at that point of time, what was said when we are trained was, if you have a difficulty or if you ended up in a problem and in between, you can stop the procedure and come out. Having you debulked a significant amount of the gland, by the time you reach the capsule, possibly you may not require any more procedure. Patient may be able to pass urine. That is the concept why the whole thing has started. But of late, the whole concept has changed and complete resection has become the mainstay of any TUR, not just making him pass urine. So we are looking at resecting right up to the capsule and making a better resection. That's all. I feel the difference between Burns at that time and the Nesbitt later is because of a better instrumentation, camera, etc. Burns never had a camera. Nesbitt had a camera, so the whole things are different. What do you say, sir? Tripeka, sir?
Yes. Look,
am I right with that?
Yeah, you are.
Mali, there's another question. What is the irrigation which you're using? Obviously, it will be saline, but their question is, what is the speed of irrigation? Should it be the same for monopolar and bipolar?
Absolutely same. The height of the thing, what we decide, usually matters. Once upon a time, when we are doing a monopolar, we are keeping a 0.5 meter height or a 60 centimeter height. Beyond that, the increases the incidence of TUR syndrome. That maximum 1 meter, some people used to give for 1 meter. But of late, being saline, the size really doesn't matter. Sometimes if the bleeders are little high, we keep a little higher height so that the vision is better, the flow is better. That's all. Nothing. I don't think we give much relevance to that at present point of time.
One of them was asked, how often do you lubricate the urethra during the procedure?
I don't think I haven't. I really don't. I put around 20 cc of xylocan jelly at the starting point. Later, I don't. So this
actually,
is
if you are doing a large gland and if your resection time is exceeding 30 minutes, I think so. At the end of 30, you can ask your assistant to put some jelly at the urethral meatus. That is our practice actually.
Yes,
and
true, sir. True, sir.
And the second thing is your movement of your instrument. If you are feeling any tightness or something, you should better lubricate.
True, sir.
The other thing I want to share my experience. I don't know. This is an Olympus workshop. Then I will not talk actually about
this
these
one,
thoughts.
sir?
Is it Olympus workshop sponsored by Olympus?
No, sir. It's sponsored by ISU, sir.
I want to share my experience of I'm using Storage bipolar, and they have got thin loop and thick loop. In bipolar only I'm talking. It's a 20 millimeter loop thin. This is normally what we use for the bladder tumor. And we have 40 millimeter loop that is called thick loop that I'm using for the prostate. And current, I have already said, we have a setting for both coagulation and the cutting, 4 and 5. That is normally what we keep. The second thing is the movement, as we have already discussed. If you are having a slow movement, your cutting has to be smooth, there is no doubt. But if you have a slow movement, your simultaneous coagulation goes on and your bleeding will be much, much less. Point coagulation, I 100% agree. And when you are doing with bipolar, that duration of the coagulation at that point has to be slightly more than the monopolar. Otherwise, as you know, the heat generated is less in bipolar, so that this bleeder may open up later on. Initially, when this bipolar was started in 2002 or 3, there was this was discontinued also because of the fear of the lot of persons that lot of bleeding is there. So they were very fast in cutting. That's why there was more bleeding. But I'm very comfortable regarding the technique. I do. I have already videos which I have shown earlier also. I go to the capsule first. I start, if a small gland 30, 40, you can do median low from 6 o'clock. Otherwise, I do 5 and 7, as Malika has shown very nicely. Then I do Nesmith. Same, I go to the capsule at 12 o'clock. I start, go to the right and left. And first, I do the enucleation type, like in HOLAP. And then I just resect the loop very fast, actually. So that is the way I do more than 100 gram if I have to do large gland.
Mali, I have used both. See, the Curis and the Stowe's Autocon, they are very good when you cut. But I have used the local bipolars. It's not as good as Curis. There's a difference in the machine also. The Olympus and Stowe's have got very good bipolars, but the local Indian make bipolars are not as good as the Olympus one.
Agreed.
Now having almost done the debulking of the area in the main part of the prostate on one side, that is on the left side of the lobe, I'll not go right up to the right up to the capsule now. I'll keep it for the to the end, and now I'll look at the bladder, this apical area on that side. I wanted to just tell them the problem is, whenever you do an apex, like somebody was asking, when it goes beyond the thing, what happens? Whether it is beyond the verumentanum or not beyond the verumentanum, the technique of resecting the apex or should be its same, so that you can keep as much smooth muscle as possible under the inside. That is, the length of the lithosphincter is going to be intact, and the longer the lithosphincter, the better they're going to be the continence. So that is what is necessary. I've reached the capsule at majority of the points near the bladder neck and midway of between the bladder neck and the prostatic capsule. But now looking at this point, now this is the veru and this is the apex. And you see that there is some amount of tissue which is there. I need somebody to observe. This is the apical tissue. Majority of the times people start putting the resectoscope here and start cutting it like this. So when you cut this, this is gone. This is the lithosphincter area from here till here, which is going to be of utmost importance. So to make it, I will always say, I'll show you the way of managing the apex, or the way to resect the apex. And after that, I'll show how to resect the right lobe in a Nesbit fashion. So looking at the apex part, I'm coming back again. This is the area and this is an apex. You have a tissue there. Keep it fixed. And you see that the left hand makes a major role. You scoop the tissue as you're scooping an ice cream out away from the can. So that is the scooping of the tissue by making a proper boat-shaped structure and keeping the lithosphincter intact and still excising the prostate, which is attached on the other side of the lithosphincter, that is the smooth muscle sphincter. So this is one thing which I think everyone has to make an expertise it, and keep that resecting it and keep that length of the lithosphincter as much as possible. Parallel straight resection is going to end up in a significant amount of reduction in the length of the functional length of the urethra, and that produces significant stress urinary incontinence. See this? I removed the tissue here, but the length of this is still maintained. So this is what I would say whenever you think about resecting the apical area, you need to be scooping the tissue from behind, and see that you export the capsule on other side. I'm clear, sir?
Yes.
Am I
Apex
right?
can
So
be
from this
What
area
what
till
I
this
do,
area.
just what I
Malik.
do for the apex is, as you showed that area very nicely, I mark there with my loop, or I make a retrograde cut. So all my residents who have seen me, that retrograde cut I make, so that I know where I am cutting. I don't have to go more distally. So that is where I save the sphincter. But you
Yes,
have
sir.
very
Malik.
nicely demonstrated.
Malik.
This is the length of the
One more thing is there.
Yeah.
I just
Yeah.
forget to mention. You mentioned about the where to cut and not to cut. One principle is, please, when you are cutting the tissue which you are seeing through your resectoscope, that you are cutting actually. So don't move blindly, don't cut blindly anywhere. So what you see, cut only that. So you will definitely inadvertently you will not be cutting here, there, or beyond a sphincter or something. So always keep in mind that what you are seeing, that you are cutting. Don't
Malik,
make this
apex, according to
cut
me,
blindly.
apex is best assessed with a partially empty bladder.
Yes,
If
sir.
your bladder is overstretched, you cannot appreciate the apex so well. Empty your bladder and you will suddenly find apex comes at you very clearly to tell you this is where I am. And so relatively empty bladder will show will help you in
always.
apical resection.
What happens is when the prostate is resected significantly, the pressure, hydrostatic pressure inside the prostatic fossa will shift this apical tissue laterally, sir. So once you decompress the bladder, it will come into the view very well.
Correct.
That's the reason
Correct.
why.
Yeah.
That's the reason why many people, when you demonstrate prostate, everybody says, "Don't show me how the fossa looks when it is when the bladder is full. Show me the fossa when it is half empty." Am I right, sir?
Correct. Absolutely.
Yeah, I agree. 100% agree with you. Because when the prostatic fossa distend, then it will stretch out. And when you will decompress, suddenly you will see a lot of tissues is still there.
So on the left side, you saw a Burns technique of resection. On the right side, I'm going to do for a Nesbit way, so that the combination, how it can be well made out. So this is the left side, which is almost complete. There may be some amount of tissue which collapses as and when the bladder is empty. You don't go on resecting it, otherwise you will end up in perforating the capsule, because once the prostate is completely resected, even the peripheral zone folds sometimes and comes as a prostatic tissue, and inadvertently resecting it may end up in you coming out of the capsule area. So whenever you assess after a significant resection, assess the prostatic fossa after a half distension. Don't assess it only when it is completely empty. Half distension is the ideal area. Sometimes you end up and there is a capsule which is folding up itself, and that is the reason why you end up in coming out the capsule. Other point is, whenever you are reaching the capsule, when you are resecting it, there is a muscular movement which comes in. You saw that muscular movement behind? So that muscular movement means you are near the capsule. Never cut, and that muscular movement sometimes moves the capsule towards you, and you may ultimately come out of the capsule also. So beware of that muscular movement. Whenever you see it, you are going to stop it. Am I right, sir?
Yep.
That may be muscular movement, or that can be the pulsation of the vessel deep.
Oh yeah.
So if you cut in that area, you may just open up the vein or the artery.
Yes, sir. Yes, sir. So the next thing, yes, sir.
Ali, what is your take on, there are some people who advise to leave a rim of tissue at the 12 o'clock position. They don't resect that.
No, I understand. I am a proponent of it, provided the tissue is very thin. If it is projecting as a lobe-like thing after the resection, I resect it at the end. Because I don't want the next patient, next urologist to do a scopy and tell the patient that he has left some tissue there.
No, it is not like that actually. If it is gland is less than 30 gram, better to leave a
yes, sir.
at 12 o'clock position. So that is a standard teaching. You do it QIP or something like that.
Now I am 30 gram prostate. I give a bilateral incision and resect the central area. Now I am going back to a Nesbit way of doing it on the right lobe. So I am taking at 11 o'clock position. I resect the tissue and reach the capsule directly. So I think I've reached the bladder neck here completely. That vessel is there. and I need to reach the capsule here directly. So once I reach the capsule, I'll be able to know the depth of how much I need to reset. I think I reached almost.
If you are
So-
resecting at 11 o'clock position, why are we not seeing the loop at 11 o'clock?
No,
Sir,
his
this is
camera is not rotated. His camera is.
That's right. So
camera is showing the actual, sir, camera is fixed to the thing. I'll not rotate the camera as it is. You want to have that sort of a vision? I'll show you. I'll unlock it. What I'll do is I'll unlock. Now, once I unlock, this is what is going to look like.
Yeah, this is
Once I unlock, this is how you look like.
Yeah, exactly. But I think all of us work with a mobile camera. Do we?
No. Most of us. No. Sir, Kirpekar sir, everyone uses that stars camera and try to rotate it with the left hand. This is an Olympus camera. It's the only pendulous camera which can move and stay in its position even if I move. You see this? Even if I move, it stays in the same position. That is there only in Olympus, nowhere else. This pendulous camera is the proprietorship of Olympus. So that happens only in Olympus. Okay. Anyway, that's not the point. But do you want to see? You want to see? That's why I did it. So I have a habit of fixing it all the time. So I reach the capsule here. You can see the capsule. I reach the capsule on the 11 o'clock position. Now I see this is the lobe. Actual Nesbitt teaching is to go all along the capsule. But I would say, isn't it? This is what Nesbitt has taught everyone. So you go all along
and dropping the lobe in the cavity.
Dropping this into the cavity. But I would say, if it is you are a beginner to work with, I would not advise this method because you may end up in getting out across at any point of time. It is only for after a significant amount of experience. So what I'll ask them to do is resect. After creating a groove, resect it immediately. After creating a groove of the thing, resect it and flatten it. That's a flatten it, right? And again, once you go back and again come to a next level. Next level again. So you will not allow the hanging lobe there. You will be going on resecting the lobe immediately. So you will not be lost in the groove. That is what is my way of doing it. So I create a groove, make it flat, create one more groove, make it flat, and keep going on flattening it till the end. You have a better control. You have a better understanding also. Otherwise, you will be lost. Sometimes the gland is so big and the groove here is going to be so deep, you'll not be able to understand where you have gone. So I would say, once you resect and come to the groove, come to the capsule on the periphery, you understand what is the lobe which is projecting into the bladder. You know what is this, and then you start resecting it right then and there itself and flatten the surface of it till the area where you have resected. So this is my small modification which I always teach the people, which I think say that you will be reaching the capsule. Don't be in a hurry, right to the bottom, and then you go back again. Go back again, resect the next level of groove, 1 centimeter below, taking the cue from what you have done above. This is the cue what you have done above. Taking the cue what you have done above. Sorry, you already reached the capsule or probably thinned out the capsule completely. I didn't notice that muscular spasm happening there. Okay. Having done that, and now you see a flattened surface, you start resecting that flattened surface. So you will not be having any lobe which is hanging into the lumen. You will be able to have a clear vision of this lateral surface very well rather than as a groove. Comment on this, sir. Kirpekar sir, comment on this.
Absolutely correct way of doing it.
Yeah, this is the way I think so you have demonstrated very well that we can go up to the capsule, come up to the midway or little bit lower, and then you can resect that lobe, and then further you can progress and make it in 2 zones instead of 1 zone completely in one loop. You cannot resect. So if gland is large, you have to either 50% or 1/3, 1/3, 1/3 like that.
Absolutely, sir. You see, the more you want to be safer, let smaller the loop size, more the chips. You want to be safe. So this is the lateral aspect which is already done, and this is a loop which is being resected. So that is the lobe which is there in the center. We resect it off, and then you will be able to manage the apex after that.
Mali, there is a question in the chat box. Sometimes we find the lobes are big, close to the veru. So what are
Yes.
the tips to resect that?
No, this is exactly what I said. You keep that length already. I'll show this in this apex again, how to resect at the apex when it is going behind. You see, I don't think that there is a big change in the concept of you, the way you do it. Whenever you start doing it, I don't think there's a big difference in the concept, the way you do it, whether you have a lobe which is extending up to this point, up to this point or up to this point. The concept is going to be the same. You are going to leave that tissue which is attached to the mucosa and that muscular and the muscle below, and take out the gland part which is inside that. That is the only concept. So for that, I'll show you again with the resection at the apex. I'm going to show that.
But if you
This
have to do an ejaculation preserving
correct. This
TUR,
will change.
then you cannot resect that region.
No.
Yeah, this will change if you're going to have ejaculation sparing technique, in which case you will have to preserve the paracollicular and a supracollicular tissue.
Yes,
and
yes.
you leave it intact.
Sir, even that.
But you can still resect the apex perfectly well.
Sir, even that in Rassler, who published it, has got only 36% incidence of ejaculation preservation. Number one. Number two, if you recount all your TURP, there will be 10% of the people in a standard TURP what you have done. 10% of the people who come and tell you that they have ejaculation to a certain extent. Am I right or wrong?
Right.
Yes, I have been doing ejaculation sparing fairly regularly now for anybody who is around 60 plus. And I make a note to find out. And I'll tell you, the success rate is not as low as 20 and 30%. The success rate is nearly 70%.
I agree with
sir.
Becker.
Because
we did a study about this, and our ejaculation preserving rate was around 68%.
Correct. This is what I have seen. You could definitely do that.
But there will be some amount of apical tissue when you rescope them.
See that this is the veru, and this is the preservation of the thing what I wanted to have. That's a preservation of the thing what I wanted to have. I'll empty and I'll show you.
You have done apex very well on both sides. Absolutely good. Again, you show us with the empty bladder, and
yes, I'll show. I haven't finished it. I'll finish it and I'll show. I'll just finish it now with this, and I'll show. So I'll go back again and again and see where I'll have located and how much is the length I am preserving. My lysosis sphincter length is proximal to the verumontanum. So I have preserved an adequate amount of length of the lysosis sphincter. So I want to preserve that amount of it. So I'm coming back to the apex and trying to resect the tissue behind that and scooping the tissue away from that muscle. Scooping the tissue away from that muscle. That is the tissue. That is the muscle. I'm trying to scoop out the tissue away from the muscle.
I think so. This is very well.
What are the tips to avoid bladder neck contractures post-TUR?
I don't know. I don't think I have an answer for that. Everybody tried everything, but it appears to be independent of all those things. Bladder neck contracture, I've seen people tried saying that in a small glands, yes, as Dr. Guptaji was saying that in a 30 grams gland, we don't resect a lot of tissue. I think that is one way. Most of the bladder neck contractures happened in a smaller glands only, but it has happened in a large gland of 150 grams where we did a whole up also bladder neck contracture happened. So we don't know what exactly makes it to contract. So we are still not clear. We are still not clear.
Can I say something?
Yes, sir. Yes, sir. Go ahead.
It's the subtrigonal leakage of saline that happens inadvertently as you keep on resecting the bladder neck is one thing which is responsible. And the second is excessive use of coagulation on the bladder neck all round could be again responsible for bladder neck contracture.
Yes, sir. Logically, all these things, sir. I would say absence of a mucosa in the bladder neck. Number two, a small bladder neck which will end up result in a smaller gland which contracts and causes bladder neck contracture. If there is a subtrigonal extravasation of fluid, you have made an opening into the bladder neck area, and there is subtrigonal extravasation of the fluid that can cause a contracture. So anything which causes more fibrosis, either excessive use of coagulation, etc., everything can cause bladder neck. But at the same time, people who had all this never had a bladder neck. People who had nothing had a bladder neck contracture. So we are not sure what exactly is the reason for bladder neck contracture, but we do all our measures to prevent that happening in some way or other, as all these points have been raised as a logical reasons for bladder neck contraction in all these patients.
In my experience, one of the factor what you, Mallikarjun, you have demonstrated initially, preservation of the mucosa around the bladder neck. So you may remain 1 or 2 millimeter inside in the prostate side instead of resecting on the bladder side. If you resect that mucosa, there are higher chances, because when healing takes place, this is basic. Healing is always by contraction. So you have to make sure that mucosa is preserved there, and that I always try to do it. To minimize, I will agree with you. Anybody can have bladder neck contracture. The patient where you don't want, he will have bladder neck contracture, So it always happens.
But if it is smaller glands, after you have resected, do you put 2 incisions on either side and leave it so that you can avoid contractures? Does that help?
I don't think, sir, Keshav. The reason why I don't realize this is bladder neck contraction is not because of a narrow bladder neck alone. People have developed bladder neck contracture even in a wide bladder neck. You don't need an incision. You see, incision prevents only when you have a narrow bladder neck at the end. By giving an incision, you are creating a wide bladder neck. But it doesn't happen. Even in otherwise also it can happen. That's the reason why. So if I look at now, this is the verumontanum. I have fair amount of the tissue which is there. Excess amount of flap which is created because I wanted to preserve as much as possible is not necessary. It is too thin. It doesn't serve any purpose. So I'm trimming that flap, but not to an extent of compromising my length of the thing. So having done that, this is the veru. All my mucosa from the verumontanum down to the area of pelvic diaphragm is intact. So this length actually is a reason for good stress, good continence, and even stress incontinence. It is not the levator which is necessary for stress incontinence, but this lissosphincter is necessary for avoiding stress incontinence. So having done all the things, I think I've resected completely. I've reached the capsule at majority of the places. There are some areas where there is some amount of flappy tissue is seen. Those areas, I'll start doing something called toileting. What you do at the end, after you finished your resection, is called toileting the whole prostate and you create a nice space around, and you take care of the hemostasis also at the same point of time. Comment, sir.
Mallikarjun, it is not called toileting. It is the shaving. Blandy's book, you can go back. He called it a shaving of those small chips here there.
Yes, sir. That's
shaving
all. That's
better wording.
That's all. See, wherever there are elevations, as a surgeon, you feel a good, nice cavity you want to look at, and that is what you try to achieve. I would never try to resect this bladder neck excessively, sir. The bladder mucosa, these fibers is to be left behind. Unnecessary excision of that fibers is not going to be of any use. There is some bleeder which is making my vision a little poor. Possibly I need to check that where it is exactly.
And why you should do adequate resection or removing these small chips also, because they are the one which can give rise to secondary hemorrhage. They get necrosed, dissolved, and patient may start having secondary bleeding. So you should try to clean the capsule as much as possible.
So the most common areas of a postoperative bleeds are small bleeders from the prostatic tissue doesn't bleed. The major bleeders are bleeders between the bladder neck fibers and the prostatic tissue. That's where the major vessels will enter the prostate. So try to look into that area and try to have a good control of those vessels at this area. So this is the bladder neck, and this is the prostatic, and this is the junction where they are going to be seen. So look for bleeders at that point and try to resect all these bumps, and don't bother about the crevices, but bother about the bumps there and resect them.
The artery of flock is a very definite structure that you see at 11 and
Yes, sir.
1.
Yes.
And that's the one which has to be taken care of. Commonest cause for a secondary bleed or a post-TURP clot retention is that. So finally, looking at 11 o'clock and 9 o'clock at the bladder neck, junction of the bladder neck with the adenoma is the area that has to be taken care of.
Sir, that's exactly what I say. Majority of the resector scopes which have a beak-like thing, that beak will compress that areas and they don't bleed when the resector scope is inside. When you withdraw the resector scope, then only they start bleeding. So try to look at, majority of the times the bleeding is in the roof because it is compressed by the beak of the resector scope during a normal resection. So I always tell the people, so look for the roof and then decide, and then finish the resection. Never say that the hemostasis is complete without looking at the roof. What do you say, sir?
Absolutely correct.
I have some tissue still, which I'm resecting.
Hello?
Again, I'm talking about half loop. Use a half loop. Never try to use the loop completely. Half resect, half to cut, and half to assess the depth. So that gives you a better knowledge of how much to resect. So this is what I always say. It doesn't matter. People don't use the loop completely. Using the loop completely may have more problems because you don't have a control of the loop and the depth of the loop at which it was there. What's your take on that, sir? Half loop resection. Hello?
Hello, can you hear me?
Yes, sir, I am able to
Yes.
hear you.
So half loop, what you are saying is when you are doing with half loop, you can see the other half loop, what is the depth you are cutting. I think
Yes,
so
sir.
for the experienced surgeon, you know what the loop, again, depth is about 3 to 4 millimeter, and you know how much deep you want to cut. So accordingly, whether you see the loop or don't see the loop, it's not going to make much difference. So wherever you think that you are going to have a problem, means there may be vessel inside in the depth, you make a small loop superficial cut. Otherwise, when you think there's a large gland, you can make a deep cut. So that is the
No,
way I
sir.
manage.
Yeah, absolutely, sir. And I'm talking about people to learn. That's better way so that they have a control on it. That's what I'm saying, sir. See, once you have reached your this thing, I don't think that makes a much difference. You know where it is there. By seeing it itself, you say that whether you have reached that area or not. But for people who are beginning, I think that's a better way to have a better control and go slow. Going slow. You may take a little more time to resect ultimately, but it matters. It makes a fair amount of safety profile for your surgical intervention.
With expertise, a urologist should be able to produce a specimen which is boat-shaped using the entire depth and the length of the loop. And that's the ideal resection.
Yes. And that's what I was talking about. To create that boat shape, it is not your right hand that need to be used. It's your left hand. Keep your left hand active. That will give you a better control than the right hand. If you're cutting and also causing a boat shape at the same point of time, that is going to be on the right hand alone. That's going to be quite strenuous. So use the left hand for that, creating that boat, and the right hand to cut will be a better way of doing it, sir. So this is a...
Mali, continuous versus your intermittent. I feel, see, if you're doing continuous, your pressures are always low and you are getting the tissue to be resecting easily. Because you are doing intermittent, the pressure is there, the tissue collapses and it's moved away. Then you empty it, you find more tissue coming inside.
No, I don't deny. I don't deny your this thing. I'm telling you, no, that's exactly what I'm saying. But if I have a gland of a 60 grams or 80 grams, I'll definitely do with a continuous only. This I'm taking a little more time for demonstration. So majority of the times routinely, I wish for today probably I would have taken it. But anyway, that has been my routine. So I just adopted to the same. I think now, are you happy with the whole resection now?
Yeah. We hope with a very good demonstration. There is no doubt. And it is good what Mallikarjun is showing intermittent also, so that the delegates, they should also know, because this has been our technique also till we started using continuous suction irrigation system, So I think so. Let them be exposed to as many techniques as possible.
No, there are people who use 24 French intermittent, but they put a supracath. They put a supracath for irrigation.
Yeah. That is also routine.
Sir, but I somehow I don't like, sir, because that supracath starts leaking around the around the catheter, and there is retropubic extravasation that can happen. I don't think that is anyway. Everybody has got their own way of doing it, but I think I've done the resection. My hemostasis is fairly decent. The urine is quite clear. So at the end of the resection, what I look for any chips inside. I'm going to do an helix now because there's some chips there. And I'm going to look for where the ureteric orifices have I preserved. Yes, the left ureteric or right ureteric orifice, and the left ureteric orifice, fair amount of trigone is left behind. So, and I have not opened the plane between the bladder and the prostate. This is the plane which can get opened. What Deepak Pekar was sir were telling. Looking at again the arteries of 4 o'clock and 8 o'clock, which supply the median lobe area, and see this is the blood vessel. This is the blood vessel, and coagulating it, and look for that 1 o'clock arteries, which will be the major suppliers for the prostate, which have already been coagulated. Looking at the roof, which is not going to be bleeding, and looking at onto the 11 o'clock area, and this is the area where we coagulated the artery here, and looking at the rest of the things. Are there any small tissues which are left behind? You resect it off. And don't go for it. There was a muscle contraction here. It appears that as if there is a projection, but still I don't want to resect it because this muscle contraction was there. So be careful of resecting that area. Another muscle contraction may allow you to go outside the capsule. So that is what we need to go look into. So this is the capsule, and I would prefer not to coagulate too much at the sphincter area. These bleeders which are seen here, they do bleed when you are seeing atem, but they don't bleed later. So this is the length of the sphincter, which is where intact. There is no injury there. I think this is the end of resection, sir. Okay, sir?
Yeah, very nice. At this point, Malik, would you like to change to a button electrode and do final vaporization of small bits of tissues which are around?
No, sir. It is too much of a magnification. We end up going on doing it, but this is already a 4K cam with too much of a magnification on it. What I'm showing is a significant magnification. I don't think I need to deserve it. And I always, I don't think I'll do it now. But in case, sometimes if there is a lot of bleeding, some ooze, I'll definitely do that. But I use it for more a coagulation than resection of the tissue or vaporization of the tissue. I always tell the juniors saying that you need to look into the bladder whenever you have done an helix. Don't say that helix is the end of the procedure. You need to look into the bladder after helix for two reasons. Have the pieces have come completely in an empty bladder. Number one. Your helix itself, see that there is one chip which is still there. Your helix itself would have opened up some blood vessels now and then. So look for a blood vessel which is bleeding after helix. This is what is a mandatory thing which need to be done by everybody. People will just do helix and put a catheter, which is not correct. Your comment on that, sir?
Agreed.
I agree with you. Always at the end, you must look in again before you take out your sheet, and you distend the bladder. So when you take out the sheet, there will be a good flow of urine. You can assess the result on the table also.
Yes, sir. At the same time, the advantage of that is actually more than the flow. The advantage is if there are small chips in the prostatic fossa, they get cleaned off. These clots will come away along with the flow initially, sir. That's the reason why we need to do that, sir.
Before coming out, I normally shut the inflow, keep the outflow on in my Iglesias instrument, and that often shows you small bleeders
chips
which have
coming.
not been seen so far.
Yes, exactly. So when you need to stop the irrigation and see, and when the outflow is on, you will be able to see if there is any venous bleeders which you missed because of a high pressure inside the bladder. Am I right,
That's
sir?
correct.
Yeah,
That's exactly. So I'm looking for those pieces. I don't see any pieces. I don't see much of a bleeding inside the thing. There's a small flap of tissue which can be resected, which need not be resected also, that gets stuck there into the roof. I think I resected. It's creating a big flap there. Yes. So I'll take care of that. This extra tissue need not be resected because the sphincter lies very close to that area, like in Moleps and in this area also, we don't resect it. I think I've completed the resection. I'll do the helix and I think you can go ahead with the next case, sir. Am I fine with it, sir?
very well done. Apex
Thank
is
you.
very
Very well
nicely
done,
done.
Mali.
We can see
And
the sphincter well.
And the irrigation is absolutely clear. I don't put a traction routinely in any of these cases because I believe traction produces more incidence of strictures. Because I would say nobody really discusses it. But whenever we keep a traction, there is a friction in the penoscrotal junction area, and there is a friction of the urethra under the perineal diaphragm. So these are the two traction points wherein there may be a stricture that can happen: penoscrotal junction or a bulbomembranous junction. This I strongly believe. So that's the reason why I avoid as much traction as much as possible. I don't really routinely keep traction at any point of time. I think I finished. I don't see any pieces there inside. Okay. And
Yeah. I will like to mention that I will always like to put a small traction, penile traction, as Dr. Wadhwa has taught me. And so that, while patient may be under spinal, when they come out of the anesthesia, they may jump and all that. The bleeding may start. Your sister may not be very attentive in the ward. So to protect yourself for a few hours, by evening round, when we come 5, 6 o'clock, we take out that
yeah,
traction. So that is
few
my
hours.
standard.
Yes, sir. Few hours is right, ideal, sir. But if
Yes.
at all people keep it for the next day morning to happen, I think it is not advisable, sir.
Yeah. Then
So
you
I fill
assess
the
in the
water, I'm
evening.
taking it out. I'm seeing the urethra all through when I'm coming out and seeing that everything is fine. Now I'm going to put my catheter and see the flow, and then I'll put my catheter, sir. Thank you, sir. I think the next case is ready. They will present the case and the next case. You can continue a discussion for 2 minutes. We'll continue with the next case.
Wonderful demonstration.
Thank you, sir.
Very
And
nice.
wonderful talking also, showing each minor details and all that. Thank you.
Sir, we're going to the next case. Give us 2 minutes time. We'll check into the next case.
In this 2 minutes, if Arun, can you allow me to show 3, 4 anatomical slides which I have made for my presentation and my technique of doing the QRP? If you allow me, I have kept it ready.
Please, sir, you
Just
have to share.
take 2 minutes on the
Please
4
share the
slides.
screen. Go ahead, sir.
Sorry? Can I share the screen?
Yeah, please share the screen and go ahead.
Actually, this is the blood supply of the prostate. And as you all know, the inferior vesical artery branches, prostatic artery, and these are the artery of the flocks. They enter at 9 o'clock and 11 o'clock position. So these are the main supply which goes to the median lobe as well as to the lateral lobes. Then we have got these butonox artery. They enter at the apical area, and these are the main sources of the blood supply. The important point to notice is that most of these blood vessels are entering at the capsular level laterally, not medially. So if you control these vessels here laterally, I think so a lot of the bleeding problem, especially large prostate, I'm talking, can be taken care of. And in this sorry. So here I'll go to the next. So in the this what I do actually start at 5 or 7 o'clock and do this group which you have seen. Mallikarjun has nicely demonstrated, and then this median lobe becomes avascular, and you can resect fast actually. So this is we want to complete the job in 1 hour and like that. We don't want to continue even 150 or 100 gram prostate or 200 gram prostate. So first we make the groove and resect the median lobe. Then we resect the one side of the lobe. We start at here and taking care of the vessels first. And then we go to the other side. Similarly, we do like this on other side. So this is the way this is called, I have named it as the anatomical resection of the prostate. So this is the way I'm doing. I have video clip also, but because of the time, I will not show you here. Okay.
Thank you, sir. Thank you very much.
We'll go out.
Dr. Malik, over to you.
Okay.
Somebody to present the case?
Dr. Tisha, you can see some few questions in the chat box. Anything pending is there, you can just discuss with the moderators. Anything is there in the chat.
There was one, Dr. Deepak, there was one doctor asking the chips get stuck to the loop, especially in monopolar. So what are the tips to avoid that?
Arun, you are able to hear me?
If you use
Sir, we can hear you, sir.
Acha, I'll present the case with the discussion can happen.
So 72 years male with hypertensive, present with obstructive LUTs for 5 years, DRE, grade 3 prostatomegaly, benign, serum PSA was 10.9. So MPMRI was done, PIRATS 2, ultrasound showed a PVR of 190 cc, Euroflow showed an average flow of 3 ml, Qmax of 13 ml per second.
So, Taif is doing this case. Dr. Taif, you're online. You can have a discussion there, sir.
we have,
Taif, you're online.
we have a 190 gram prostate. And you are able to.
Good morning, everyone. I'm audible, sir.
Taif, we are not able to hear you.
Adjust your mic.
Can we have the PIP other way around? Larger endoscopic view and a smaller surface view. Yeah.
Taif, are you able to hear us?
Hello. Yeah.
Hello.
Can you hear, sir? Hello.
Yeah. Get him. Yeah, get him up and about mobile. I'm coming to the hospital later. Get him up and about mobile. Okay. Get him up and about mobile, full diet. Yeah. Okay.
Hello, Taif, can you hear us?
Hello.
Hello.
Hello. Pashek. Visava. Samandi building आहे.
Sir, hello.
Hello. Taif, you're not audible.
Hello.
Hello. Yeah. Now you are audible. No, not very clear
Just-
still.
Yeah, just one. They change the mic now.
Hello. एक निकाल दो, दो क्यों लगाए? Which one is functioning? Both. Suddenly one is going. Hello, sir.
Yeah,
Hello.
Taif.
Sir,
Yes,
good morning,
we
sir.
can
Am
hear
I
you
audible,
now.
sir? Yeah.
Yeah, you're audible now.
So you had the case presentation, sir?
Yeah,
Sir.
we saw that
Yes.
it's a very large gland. So
Yes,
tell
sir.
us your plan.
Irrigation, please. So this is a pretty large one. So we'll be starting off first with tackling the large median lobe. As we were discussing in the first case, here this would need making the grooves at 5 and 7 o'clock, devascularizing the gland, median lobe, and then resecting it. And then we'll go for the lateral lobes. So the most crucial landmark when we start resecting the median lobe is the ureteric orifice. So this is the ureteric orifice. We have a fair amount of safety margin where we can start. So I'd be starting first with the 5 o'clock groove. The principles have been the same that has been discussed in the previous case, making the groove till we reach the bladder neck fibers, basically to identify the arteries which have been demonstrated in the previous discussion and cut off the supply to the median lobe. Taking care that we don't over resect at this initial few minutes, risking undermining and subtrigonation kind of a thing, like again was discussed, which increases the risk of extravasation of the fluid right up front. So that is one thing that it happens in the initial few moments of the surgery, increases the risk of higher amount of extravasation happening. So it is acceptable that if we slightly under resect at the bladder neck at 5 and 7 for the median lobe, and we can as well come back as the last step of the procedure to resect out whatever is left behind. So I'm deepening the groove at 7 o'clock now.
But your technique of resection is taking smaller chips faster. Is that the
Yes,
way?
sir. Yes, sir. So my sort of thing is I tend to rely more on the speed of the cut of bipolar and go back and have a quick point coagulation rather than the conventional thing of going a slow cut with utilizing the coagulative effect of the slow movement.
But then won't monopolar would be better than bipolar in that case?
Uh, Not much of a experience with monopolar, sir. But eventually it would be the same, sir. I don't think so. There's much of a difference between monopolar and bipolar. One more technique that we can look for resecting of a large median lobe is rather than resecting here, we can start resecting and debulking the median lobe from above. This would give us space and a safety margin that we debulk the median lobe adequately before getting close to the bladder neck or the ureteric orifice. So especially large overhanging median lobes, this would be a safer thing. Come from above rather than proceeding and widening your grooves. So
what is
once
your
you
tip? What is your tip to resect the median lobe? Suppose you find a large intravesical lobe which is projecting into the bladder.
once we try and debulk, if it is very large, we will find a flap which is happening here. So if that is the case, if this is slightly more overhanging, I get a hook the flap inside and then take a shortcut rather than taking a very long cut. Go close,
hook the tissue, take it into the closer to the sheath and just give a small cut. So that way you would be fairly confident that you have not taken any trigonal tissue inside your loop cut. So now we are slowly approaching the bladder neck fibers. We go back, reassess. We might be having some amount of tissue further left here, which we can resect back safely at the later part of the stage, rather than risking a subtrigonation at this point. The advantages, again, the classical advantages of opening up a channel for clear irrigation, improves the vision. And once we start releasing the lateral lobes with any modifications of Nesbitt technique that we do, we need a space in the central part of the urethral canal for the lateral glands to fall. So there's still adequate amount of tissue in the median lobe that we can resect later on. So my first task of debulking the median lobe and creating a channel is done. So at this point, I would proceed to approach the lateral lobes and come back to this tissue which is left behind along with the remainder of your lateral lobes. So we come back. The main landmark again is the zone of contraction of the sphincter and the length of lysosphincter that you would want to leave. The classic landmark would be our verumontanum, but here we have sufficient amount of overhanging tissue here. So we would need to debulk the gland adenoma here. So the junction of the white line of Hilton, which is the junction of the mucosa and the adenoma inside beneath, this is the actual landmark that we have to debulk eventually for having an appropriate and adequate resection, whichever technique we use. Either we go for a TURP or for any kind of enucleation. So we start right lobe resection. So we start at 11 o'clock, 12 o'clock kind of a zone and deepen it. Target is to devascularize the gland by reaching the vessel. Once we reach the capsule at 11 o'clock, our next option would be either we proceed and laterally debulk it. Like was shown, we can increase and resect and make it grooves layer by layer, or we can keep proceeding, making and enlarging the groove and slowly detaching the lobe from the capsule. Akin to what exactly we follow in most of the enucleation techniques. So we keep following and tracing the capsule and mobilize and devascularize as much of the gland as possible. So coming back, reorienting myself. So I have not overshot. I go back again marginally inside for an additional margin of safety. So from 12 to 9, fair amount of detachment of the. Hello?
Hello.
So I have to some extent separated and reached the capsule from 9 o'clock till 12 to 9. So as much as possible as the gland moves medially and gives us a space to widen this group, we can proceed. Now we have devascularized the gland from the feeder at 7 o'clock and the feeder at the 11 o'clock. So this is basically predominantly an devascularized adenoma which is fallen medially. So here we can go and debulk it more rapidly. So here, since there is no vascularity left, it would not make much of a pertinent difference practically as to what approach we do. The only thing that we have to keep in mind is not lose orientation as to where we are resecting and have a quick debulking effect of the lateral lobe which has fallen. So we can notice there is hardly any vascular supply which is left. So it is akin to almost morcellating in situ the devascularized adenoma.
But actually, to get the effect of the bipolar, you need to resect at a much lower speed than you do it in the monopolar.
Okay, sir.
Because at this speed, I think even monopolar, you can resect as good in monopolar also.
Sir.
You're doing an excellent job, and that's why everybody's quiet watching you.
Thank you, sir. I'm pretty nervous to demonstrate in front of stalwarts and big people like you, sir. So I don't know how much of it is my efficiency and how much is my nervousness in dissecting this.
Well, I don't see your hand shaking. You're all right.
You are doing a great job. And this is exactly that technique which I have demonstrated. This is the, he's just sees this whole lobe can be resected very fast. So when they say, how can you resect in 60 minutes, 100 gram and all that, I think so his speed is also 2 to 2.5 gram per minute.
This is replicating the principles of enucleation with the dissection loop, sir. What we do with enucleation, we use either bipolar energy or laser, whatever we use, we do the same thing. We try to detach the adenoma from the capsule as much as possible and push it back. So what we are doing is instead of pushing back, we just push it medially and then sort of manually morcellate it.
Correct.
No, your control of vessels at 11 o'clock and at 5 o'clock was so perfect. And that's why this entire lobe is avascular.
Yes, sir. We evolved this thing basically from what modification we were trying to do with our TUEB technique, bipolar enucleation, where we were separating it from all around and keeping it attached at the verumontanum. So, and eventually resecting it in fossa. So eventually we realized that what we can do with the bipolar enucleation cannula, spatula, we can do the same thing with the resection loop as well. So this is basically a replication of the same principle in a resecting manner.
Yes, Mallikarjun is there.
Yes, sir. He is there, sir.
No, the question I want to ask you in your center, I will say, you are doing both that spatula enucleation and now you are showing this technique. Have you compared or try to see which one is better so that we can come out with some, consensus? What should be done, what should not be done? For the young person, it is very confusing for him what to do, what not to do actually.
Sir, but basically what happened is, are you able to hear me, sir?
Yeah, I am able to hear you.
So basically what happened is we evolved a bipolar enucleation technique, wherein we enucleate everything, keep it to the verumontanum and then start resecting it. So, but unfortunately what happened is many people are not able to adopt to that bipolar thing, sir. So they are more familiar and more easy. So to create more, to clone people, this was easy. In fact, Taib has adopted that very well and he resects very fast. So he adopted the technique of that bipolar enucleation along with resection at the in situ, even before it is completely enucleated. So that's how it evolved. But we have not got a comparison between the two. We have a comparison between a regular bipolar TURP and enucleation, which we have published already.
No, but why not to popularize this thing, what he's doing? That is my saying actually.
So this is mostly, this is what majority of the times we do it, because today morning we just did it because for a learning purpose, a standard technique is always better.
No, with this technique, most of the urologists, practicing urologists, would like to do this instead of enucleation to begin with.
Yeah, of course, sir. Enucleation is not going to be so easy. I think especially bipolar enucleation is a tough procedure to learn.
Yes.
No, but what he is doing, it is like enucleation only,
Yes,
it is
sir,
not.
definitely.
So why not? What Deepak is saying, we have to think of there are now 3,000, 4,000 urologists in a small place. So how comfortably we should standardize the technique and give it to them so that they are happy to do it instead of
Absolutely.
trying that one like that. That's my feeling. I don't know. I may be wrong also.
No, sir. This is this exactly when it is. See, the best technique will be a technique which will be replicatable by everybody.
Yes.
So if
Yes.
it's replicatable,
Yes.
that's wonderful, sir. That's exactly. In fact, I'll ask Taib to demonstrate at multiple places so that it will be easy.
No. I exactly do what he's doing actually, and this is my video clip are there in YouTube. One can go and see also. And I have described this anatomy with, after doing so many cases, we also were puzzling ourselves what is the best way of doing. So then we discussed in our department, we have residents who help me, and we have about 100 cases we have done like this technique, and we are very satisfied. So all my cases are done like this only.
So we have debulked the gland to some extent. Still some amount of tissue, rather a large amount of tissue still remains. So here we can take thicker chips and at a faster pace until we reach the capsule.
When you reach to the capsule, I think so, then you take small chips, And
Yes,
when
sir.
you are on the surface, you can take the,
Yes, sir.
extended.
The speed
You are
and the aggression of the resection can be higher at the start of debulking the adenoma. And once we have debulked most of it and we are closer to the capsule, we need to taper down the depth of the chips. And as the classic teaching goes, shallower the chips, closer to the capsule.
correct. That is the way.
The most important thing in this is when you do your first cut at 11 o'clock or 1 o'clock,
Yes.
you must do it deep enough to get the vessel control, but not deep enough to open the capsule at that point of time.
Yes, sir.
You must remain just short of capsule with a good vascular control. If you achieve that, then this is the best way of doing lateral lobes.
Yes,
See,
sir.
when you are doing this large gland, I think so when you start cutting, you see the anatomy and you will recognize you are going close to the capsule. So in the first 2-3 bites, you are not going to open the capsule at all, actually.
So having this tissue at the apex will come in the way of achieving a complete debulking of the adenoma because the hinging effect will happen. So as much as feasible, we would be debulking and coming back later once the opposite side is debulked. So I would debulk it for some more extent and then proceed for the left lobe. The main point of caution for someone trying to start this technique would be not to breach the capsule upfront. So one of the major limitation is we target the capsule upfront. So we should not be causing a perforation in the initial few minutes. That would derail the procedure in a big way.
Absolutely, that's the trick. You stay short of capsule.
Yes, sir.
With good control of the vasculature.
Unfortunately, what I have been noticing is that there is a lot of fear factor amongst the youngsters regarding TURP, and they feel that there is an impending perforation that might happen very early in the procedure itself. So, irrespective of the technique that do, I think that fear has to go, and the intent of resecting completely to the capsule at all the places has to be developed. Instead of creating a channel and the intent being that, yes, the patient may avoid with this kind of a channel. So that will help us proceed and develop ourselves into better resectioning people.
I also do one thing I would like to add here, that after doing the medial lobe, suppose it is very large, I will break and I will wash the bladder once and then
Yes, sir.
come back and start, because these pieces are coming back to
Yes,
the
yes, sir.
prosthetic again and
Exactly.
again.
That was exactly on my mind, sir. Because now these chips are falling back and troubling.
Yeah. And also it is better to do an interruption once actually, so that
Pressure
intravaginal
in the
pressure will
bladder
come
is.
down.
Yes, sir.
Sometimes, you never know, your outlet may be blocked or something, then things may go haywire here, there. So
Yes, sir.
safety is more important. You
Yes,
can
sir.
wash once, there is no problem. And even with Alex, you can evacuate the chips also.
Sir.
Whatsoever comes out,
With all
then
the
you
new
can go back and
technologies,
look again and start again, fresh anatomy.
yeah, with the all new technologies emerging for management of BP, resection is still going to remain a mainstay for average urologists. And so they must know how to do a big gland like this.
But what's happening is the industry is
Deepak,
driving the
I
industry
tell
is
you,
driving the younger people
I tell
towards
you
laser.
that this is what Krishna Murthy want to say, is the same I want to say. This transurethral resection of the prostate is a very technically skilled procedure, has to be done properly if you want to have a good result. Unfortunately, what has happened, that one paper which was published in 1989 from the in Journal of Urology, where they have done 4,000 cases in about 40 centers like that. And the complication list which is shown there, that has been shown everywhere in all kind of lasers and promotion of other techniques for the prostate management. So I don't deny that all those advances not to be understood or to be practiced, but in selected cases wherever it is indicated, not in all cases. So TURP, I agree with you all, is going to be a gold standard and will continue to be the gold standard, maybe next 2-3 more decades, till something comes like that, which can be practiced in many hands, not only selected hands. That has to be the criteria.
Yes.
What I mean to say is Rejam and to this that prostate cliffs and all that. I think so. They are good, but selected cases, not every case. Unfortunately, what is happening is that once a new procedure comes, everybody start trying that procedure on every patient, which is not correct actually.
There will be definite indications for such procedures.
Yeah,
but
yeah.
Common person, for a common man, because again, you have to consider the financial aspect to it. In the Western world, that aspect doesn't come in the picture. But for us, that's going to be a very important aspect, that the patient should be able to afford it.
No, these procedures have come up in the Western world is because they want to treat them as daycare. For them,
Yeah.
the reimbursements, all these things matter. So all these innovations which they are trying to do is mainly to look at procedures which can be daycare. But for a country like ours, where daycare is not going to be that easy, because you want to send some patients. In my hospital, patient doesn't want to go even if it's a daycare. He'll tell, I'll stay one more day and go.
See, what I have seen in my life, that patient, they don't have a cot in their house to sleep on the, cot. They sleep on the floor and all that. So in AIMS, they all used to beg to us, sir, let me stay here 1 or 2 days extra, so that I have full recovery before I go home, like that.
Correct.
And with the cancer, they don't like to go home also.
Empty.
If you resect completely one lobe, including the apex, or you leave the apical tissue and finish it last?
I'll proceed now for the left lobe, sir, and apex will be at the last, sir. Because for a proper resection of the overhanging apex, debulking of the adenoma would be essential, mandatory. Only then, like sir was mentioning, the apex will define itself as to how much of a tissue is there and where is the junction of the tissue with the underlying structures, and then we can scoop it out. So unless we have a proper debulking of the lateral lobes, it would be inadequate resection of the apical tissue. So this is the same thing which is. I can
I
resect
agree
to
that
some extent.
you can do the apex later on, but
Yeah.
as far as the lateral lobe is concerned, please complete one lateral lobe, then
Yes,
move
sir.
on to the other lateral lobe. Still,
Okay,
your
sir.
lot of tissue is there on the lateral lobe actually. So go to the that capsular level, so you define your plane where you have to resect.
Okay, sir.
You can start at 11 o'clock again, go back on and
Yeah.
start seeing from there. Gradually, yeah. Good. Now, yeah. So I'd like to complete one lobe, then I move to the other lobe. Why also important? Because something happens and you may have to stop, then you can come back another day and complete your other lobe then.
Yes, sir. Very taken.
Yeah, good.
Sir, may I ask what is the incidence of stress incontinence in large glands? Gupta sir, Kirpekar sir.
If you have apical lobes extending far beyond verumontanum, and if you're not careful doing the apical lobes, there could be a incidence of incontinence. Stress incontinence after a large prostate may be there for a couple of days, maybe few days, but should not be really a matter of concern. That's a perf there. You can see it very clearly.
This is a perforation that has happened.
Yeah, that's a very clear-cut perf.
So this is one of the reasons that in large glands, when it extends too laterally, there will be a contraction happening, and inadvertently, the same point which was being discussed, there would be a contraction of the capsule happening, and it tends to move inside much more beyond what you intend to cut, and making the cut a lot deeper. So whenever you want to,
this perforation is at the apical area on a lateral side, which is not of such a consequence. But if this opened into a sinus, what would you do now?
we will have to coagulate as much as possible. If it is not settling down, then
you cannot coagulate a sinus. Like that.
I meant the adjacent tissues where the bleeder is there. The another salvaging technique would be lift a flap of tissue just distal to it and place it over it, and sealing kind of a soldering kind of effect can be done. So that tends to bail you out on few occasions. So it acts as creating a flap of tissue getting fixated over the opening of the sinus.
There's a question in the chat box. Should we also start doing newer techniques like prostatic artery embolization? Cardiologists are taking our prostates.
Sir, it is the radiologist who are taking away rather than the cardiologist. Sir. Patients are not reaching the urologist at all. Grade 2 prostates being picked up in health checkups, and radiologists are referring it to interventional radiologist for embolization.
But it's not an easy procedure. We have had demonstrations during live workshops in Bangalore. It's not an easy procedure for people who have done.
My answer, in our institution, we have done some cases by our interventional radiologist actually, and so patient who is not fit for any kind of anesthesia, and he has a prostate. I think so. There one can try. I have a patient, somebody referred directly to somewhere else in Hyderabad only, and there he got a prostate artery embolization. He had miserable time next 4 weeks with recurrent UTI, catheter all the time. He came to us, it is 160-gram prostate, and we did simple robotic prostatectomy on him, and he's perfectly all right. So he was totally fit for anesthesia and all that. I don't know, but what has been discussed just now, that cardiologists are taking away or interventional radiologists are taking away. I think so. Interventional radiologists are going to be the biggest enemy for the urologist in future. Be careful with them.
Incidence of retention of urine after PA, that is prostatic artery embolization, or resume, appears to be very high and long lasting. They are on a catheter for 4 to 6 weeks sometimes. Recently, I saw a patient after resume, and he was on a catheter for 6.5 weeks because he could not pass urine. We discussed about capsular injury and we stopped it there.
Yep.
Because sir, you are saying,
Yes.
what are the other ways of managing a capsular tear? See, there are two types of capsular injuries. One which starts bleeding whenever you switch off the irrigation, one which doesn't bleed because there was no venous injury there involved. So
yeah, the one which we are
manage?
seeing just now, the one we are seeing just now is the other type.
No, we need to go
except for extravasation. If he doesn't go back to that area and looks at it again and again, there's not going to be any problem at all. He can continue. But in case such a perforation has a sinus underneath, that really becomes a problem. You may continue. See that. There is no bleeding.
Yes.
So there is no sinus here. So that's not a threat. But if there is a venous sinus underneath, it becomes very difficult to control it. As long as you are working with a positive pressure, you won't realize it. Only when you put the inflow off, you suddenly find there's a pool of blood which comes through. Sealing it, if it is a smaller perforation, you can take 2 edges together with a low coagulating current and try and hope to seal it. But believe me, nothing of that works. Eventually, when you stop, you will have to use a traction, you will have to use a pressure to stop a sinus bleed. If you unfortunately do have a sinus bleed like this, you might have to stop the procedure and come back another day to do the rest of the.
Of late, I think after camera and all, I think the incidence of sinus injury has come down. We are able to see it quite magnified, and possibly we are not having the similar size. We are more experienced and possibly. Am I right, sir?
There's a question from somebody that he's got operator jerk during a prostate resection.
Yes, it can happen. Very, very common.
The same point that we are discussing, muscular fibers beyond the capsule tends contact.
You can develop
if it is a very large lateral lobe and the gland extending laterally, and if you are resecting with a completely distended fossa. So if that is the case, then a lot of the time, exactly what happened in this perforation, there was a contraction which brought the capsule closer. We can say it as obturator jerk. So The strange thing is it happens even in bipolar, which is not supposed to happen theoretically. If that is the scenario, then we'll have to empty it, let the fossa fall, get it more medially from the pelvic walls, and dissect it again. So if half empty fossa is there, the tendency for that jerk to be noticed is relatively less.
So there's another question that when you have capsular perforations happening, when do you decide to abandon and revisit later? At what stage?
The reason for abandoning would be from the stability of the patient's general condition.
You can still continue to
Point now with normal saline
hearing
there is no
infused
the only thing is fluid overload that might happen. We are not if you are not using glycine, so you can have monitoring of the hemodynamic parameters.
I think Malli is also speaking. Taif, one of you talk. Malli is also speaking.
Oh, I didn't realize.
Taif, you go ahead.
Yeah, one of you.
Taif, you go ahead.
Malli, you can take it. Now we are not getting the Taif's audio now.
Whenever the injury in the capsule is like this, what we saw, which doesn't bleed, in a bipolar TURP, I think you can go ahead with a resection because the chance of extravasation and TUR syndrome is very, or intravasation rather, I would say, is negligible in a bipolar TURP. Whereas if there is a capsular, if there is a vessel which is or a vein which is open, your ability to resect will come down and possibly it will start, the vision becomes much more difficult. If you can't finish the procedure in the next 15 minutes, I think it is better to stop, keep a catheter, give some traction and go back again after a day or two. Keshav, you have a difference of opinion?
No, I agree with you.
Safety, most important at any point of time. I think he's going on to the left lobe now. Sometimes we may not see one single artery coming at that 11 and 1 o'clock positions. The thing may branch out and get 2-3 branches like this one. You may have another one coming up again. So I don't know. And sometimes it is only single, but majority of times it can be double also. It bifurcates much ahead, entering into the prostate, and we start bleeding.
Malik, number of arteries can be variable, but location where they appear is invariably at same place.
Absolutely, sir. No doubt about it. Location is location. I agree on that.
See, the branching of the artery also takes place. There is no doubt.
Takes place.
Yes, when they go laterally along with the capsule, they near the capsule also they may come out. So that is all right. But as long as you are seeing an arterial bleeder, you have to pulgate it. There is no doubt.
Pulgulating artery at the capsular level is much easier than within the adenoma.
So this is one of the biggest advantage of doing this Nesbitt technique than the Barnes technique, because there same bleeder you are fulgurating again and again. Here, if you are doing at the capsular level, once is good enough. That's why this technique is good for the large prostate where you want to do faster resection actually.
And you have a good vision under control, sir, majority of the times. Once we control it, like Taif has done a devascularization of the left lobe completely now, and that gland will not be bleeding at all. You can do the resection very fast then.
Regarding, I heard, I interrupted in between for my breakfast actually, now I've joined back. So the venous bleeding, one of the technique is the compress the vein proximally, and there you fulgurate it, not at the mouth where it is opening. Try that actually, it may work, may not work. And finally, if it is genuine venous bleeding, then if you have some work to be finished in 5-10 minutes, you can finish it up fast and put a traction. That is the only answer. And sometime you put a balloon, or you always put in the bladder, and then you can put a finger in the rectum and ask your resident to press the prostate. Wait 5-10 minutes. Automatically, it becomes completely clear. Actually. So you have to wait in the theater only. Once it is become clear, then only you shift the patient. Otherwise, you may have to go back to look in again.
The point which I wanted to emphasize in the TRIF resection is his ability to reorient it every time. After some resection, he comes back, sees the sphincter area and reorients by rotation, not by moving the scope inside and out, which to be avoided. As far as possible, reorientation should happen by rotation, which is much less traumatic to the urethra than an inside-out movement of the resector scope. What do you say on that, sir?
Absolutely correct. Every time you'll come out of the prostatic fossa to reorient, you're going to have grating effect at the sphincter level.
Yes. Especially in a continuous sheath where there are that holes which are there inside, which will cause that sort of a crater effect onto that.
Only they want to know the cost of the bipolar loop and how many cases does it last.
I think it is cost effective. I think it's costlier than the monopolar, but once you get used to it, the life of the loop is good. The only disadvantage, as I said before, when you shift from monopolar to bipolar, you continue to resect in the same fashion like what you have been doing in monopolar, which will end up in losing the loops. We need to understand that it is not the mechanical cut or the force of the loop which cuts the tissue. It is the corona which cuts the tissue. So your movement in the tissue or the cut of the tissue is not dependent on the loop or mechanics. It's basically by the corona. So you need to get some adaptability. Sometime you will take to adapt it. I always say that once you get adapted to bipolar, don't go back to monopolar, or don't do vice versa, because your movement with the hand and the movement of the hand will be entirely different between monopolar and bipolar, which is very small difference, but still it makes a difference.
And there's another
Normally,
question which
life of the bipolar loop is 3 to 4 cases with one
That's
loop.
all.
You can.
Yes, that's all.
one of the doctors have asked that he has a Olympus bipolar, but he has noticed a lot of bubbling which happens. So he's asking, is there a role of temperature of the irrigating fluid on this bubbling?
Bubbling is the effect of any corona formation. You see, it's nothing but, you see, that bubble is mandatory thing, which the corona collapses into bubble, and the bubble is always there. Always there. That's the negative point of a bipolar. Yes, the efficiency of the bipolar absolutely increases by having a warmed up saline there. Warmed up saline creates a better corona with a very small period of time. So your ability to cut the tissue will be much, much more better. We ignore that point and we start having a very high cooled saline which is coming up, and you're trying to say that my bipolar is not cutting. Whenever you have that sort of a thing, you need to have a warmed up saline, especially when you're using that a little bigger loops are there. If Olympus manufactures a little spatula like small flattened loop which is more thicker than what we regularly see, it is also there. For that, if you want to use, you better use a warmed up saline which will be of a great efficiency when you start doing it. But at the end, every bipolar energy will end up in creating a vacuoles there which will collapse and causes air bubbles. No doubt about it. And that is the reason why that doesn't drain. You see, even though Taif is using a continuous irrigation sheet, he has to empty it now and then, because these vacuoles will form. They'll be staying inside the bladder, and they'll be troubling. So now and then you need to empty the bladder to get this air out, which doesn't come out of the continuous sheath. it goes into the top of the bladder. The best bipolar energy is what actually was devised by Gyrus initially, which was taken over by Olympus later. The best bipolar was that the PK, the Gyrus orange box, it's called. That was bought over by Olympus and it is incorporated into their diathermies, which shows promising and is good. I would still say it is, and the cutting part is much better with the Olympus modified version, but the coagulation was the best with that orange box.
See, I have used that orange box in 98 actually, 98 to 2002. I used to do with that. Then in between came the Wolf also. And Wolf have a thick loop also, that the concept of the pearl muter to use a thick loop. Then we came the Storch and then Olympus. So Olympus cutting, as you are mentioning, is very good, but coagulation is not very good. There is a more bleeding. And this system is new actually, which I have to use only Storch. So I'm not, wherever I have worked, I got only Storch actually, So I'm more happy with the Storch system. But it is up to your habit, whatsoever you want to use.
Ultimately, it appears to be that what we get used to it, sir. That's all.
Yeah, yeah.
Mali, you have used the Indian bipolars?
I've tried one once on that Alan, but I didn't like it.
No, there's a question which is the best Indian bipolar machine.
Oh.
I've used both Shalya and Allen. Both are good, but they are not comparable to Olympus.
No, have they done the study or something?
No, they have not done the study, sir.
Before launching it, huh?
It's only that they are not comparable to what Olympus or Stores gives. If you look at the monopolar cauteries also earlier, the Covidien was very good.
Covidien is good.
Unfortunately, our requirement remains the same, but the technology starts changing, sir. Even once upon a time, it was, you remember that the Valley Lab, which was duplicated in Thane by Eplix with the same circuitry boards. It used to be one of the most favorite machines once upon a time. You remember that, Kripakar, sir?
Yes, yes.
Eclipse. It was Technodyne Corporation was the company which started off. They just got that circuitry and then the technology changed. They are not able to match it because the whole technology is now chip-based technology.
Earlier it was wall-based.
That was all, it's all, some sheets used to come. Now it's not, it's a software-based, chip-based technology.
There's one more question in the chat box. How to assess the verumontanum repeatedly without coming out of the scope with a scope?
If you want to see patients verumontanum, you have to come out. It can't come in front, right? Well, that's exactly. You see, there is jokes apart, but the point which we were talking about is that movement of the scope is better a rotational movement, like what just now what Taif has shown. It's a rotational movement is safer to the urethra than a movement inside and outside. As far as possible, you need to restrain the movement into out and coming back it as a rotational movement. Rotational movement is safer, not the inside-out movement of the resector scope.
And every time you don't have to see the verumontanum to orient yourself.
Yes.
Once you've seen it once, you can orient yourself without seeing the verumontanum.
No, that's exactly. Your left hand should be suggesting you whether by any chance your resector scope has come out of the place where it was stationed till that time. In that case, you need to orient yourself. When you are sure it is stationed at the same point of place, in which case you don't need to orient, as Dr. Kripekar was talking about. Taif has got a separate, he adopted some principles of Rassler, what he did, like a small chips and faster chips. Length of the chips is going to be very, very short when Taif does it.
But in spite of his speed, he's still not bleeding.
Sometimes prostates also help, sir.
Oh, definitely.
Of course, our technique helps and our sometimes prostates also help.
No, sometimes even
prostate
very
is-
small prostates can bleed badly.
Hardly.
He has a very friendly prostate to do.
No, but he has got a control of the main arteries initially itself.
Yeah.
Is he using a finger active or a thumb active? It's a he uses an active working element. You see that it is coming out of the sheath. He uses a finger active one.
I am a active
And
finger man.
I always use active now.
Yeah, I am an active finger.
We have both actually. In my hand doesn't make any difference. I even don't check actually what I get in my hand. But normally I prefer to have an active one.
shall we say so the people who have had experience and become very confident, they shift on to active
About
one?
active and passive, I would like to make a point.
Sorry,
Go ahead, Taif, go ahead.
Who's there?
Hello,
Oh,
Yes, go ahead.
sir. The working dynamics of a passive element is actually anti-physiologic, sir. Thumb movements of the abduction adduction would be not physiological movements. So if someone is having a lot of resection work, a lot of work with passive elements tends to create tendinitis of the abductor muscles of the thumb, sir. And tenosynovitis is one of the professional hazards of using a long-term passive working element, as compared to an active element where the flexion movements of the fingers, which is the physiological movement, is the basis. So a lot more ergonomical as compared to a passive. For beginners, definitely the control with passive is a lot better. So I would suggest if someone is beginning for a residence, definitely passive helps. But later on, as per the comfort factor, we can shift to an active element, sir.
Taif, do you use dutastride or finasteride prior to your TRs in large glands?
If we had a chance to manage it beforehand, and if it is patient following up with us, definitely initial attempt would be with dutasteride, sir, combination therapy. But if someone has come with retention and we don't have that opportunity to pre-medicate him, then we directly go ahead. It is a relative ease that we find, sir. Not much of significance with regards to clinical parameters such as the need for blood transfusion. But definitely, if someone is on dutasteride for a long time and then comes up for resection, the vascularity is significantly less. And it is something probably you would have a happy prostate, something similar to this instead of a very juicy and a vascular one.
See, Keshav Murthy, most of the patients are already on the medical therapy and combined therapy of such a large size prostate.
Yes,
So
sir.
there we don't have to, they are already on the drug actually, dutasteride. Otherwise, if somebody just mentioned retention of urine, and then you need not to start and wait for that section.
Yes, sir. Very true, sir.
What I mean is not in retention. See, if patient comes to you, if it's found to be a large gland and he has an indication for surgery, would you put him on dutasteride for some time and then do a TUR?
No.
He'll disappear. He'll go to next
Not
block.
merely for the sake of reducing the vascularity, sir. So if it is a borderline indication where he can merit response from a medication therapy, then maybe we can give a trial, but not only for the sake of reducing the vascularity during resection.
But I tell you, in my experience, I have seen 100, 125 cc prostates, and some patients, they don't have much obstruction. And I just put them on medical therapy and they are very happy. So it is
Yes,
not
sir.
necessary that every patient needs surgery. There has to be definite indication. Not size of the prostate is not the only indication for surgery.
In fact, somehow those patients take longer time in the OPD to get convinced that they don't need surgery than convincing them for a surgery.
No, we should not forget that every surgery has got complication. So
True, sir.
until a patient have earned his surgery, we should not do it actually. If you force on him and something goes wrong, then he's not going to leave you.
If you're coming near to the apex, I think everybody was asking about how to manage the gland at the apex. I think you need to be a little slower and show that part.
Okay.
Right? You got it?
There's a question from the chat box, sir. For you, Dr. Gupta, sir. In a patient with AUR, do you want to wait for some time before you do your TR or you do an immediate TRP?
See, a patient who comes with a retention of urine, then there are some factors which we like to assess. First is the any precipitating factor which has given rise to retention of urine, like a holding of the urine for a very long duration of time, suddenly having a lot of beer and all that party. Second thing is the size of the prostate. If it is more than 60 gram and he has a chronic symptoms of the LUTs for some years before going into retention of urine, and there are changes, secondary changes in the bladder, then I'll counsel him that the best thing for you to go for surgery instead of waiting with the medicine, because nobody want to stay with a caster for a long time.
So do you find that patients with a catheter bleed a little more than the non-catheterized?
Well, most of the lateral glands, what is remaining now is the apical tissue. So we come back, reorient ourselves. This is the eventual region of the sphincter where we don't want to reach. But yes, this is the verumontanum and this is the apical tissue which is left. As was demonstrated in the first case, what we have to do is go, not recede back, stay here and keep moving. And the angulation of the working element keeps moving. So shortcuts at the angulated way would help preserve the mucosa and the lysosphincter and scoop out the adenoma which is extending beyond.
So coming to that question was asked about the catheter.
Yes, sir.
You wanted to know with catheter. Yeah. See, if you are a patient who is having catheter, there will be more congestion in the prostate gland actually, That has been observed, and usually large size prostate will have again more bleeding, and patients who have UTI, they will have more bleeding actually, Larger the prostate, more vascular it will be.
Or glands coming beyond the perimontanum. I think this is a crucial area. Kirpekar sir, any specific techniques you adopt?
Anything specific that I do? No, just be more careful, work with low bladder volume so that apex comes to you much more clearly. I may lower my cutting power settings from 120 to 110 if I'm using a monopolar, and if I'm using a bipolar, I won't make a difference. I'll continue to use the same settings.
There's another question in the chat box. Is there a practical role of trial without catheter?
I think
Depends upon.
Keshav, definitely there is a role if somebody who did not have symptoms in the past, there is some precipitating factor, small size prostate and 20, 25, 30 gram. There's no harm in giving one catheter-free trial after 5 days of the alpha blocker.
Absolutely correct, sir. Because the indications are very clear for BPH.
Yeah.
And
now coming to
another
that,
question.
I will like
There's
to
another-
give my comments also. Scooping of the what you have mentioned, Dr. Mallikarjun, scooping of the prostate should be done here so that mucosa should be preserved. And I come up to the mid of the viru. I don't go beyond mid of the viru montanum. In that, most of the cases can be managed. And you just resect the low prostate only. Don't resect the mucosa there.
exactly, sir. Exactly. The same
That is
thing
a
I
very-
think adopting there also is he's trying to preserve the mucosa and trying to scoop out the prostate behind the
Yeah.
mucosa.
Correct.
Smaller chips, controlled resection. Don't let the scope come out from the place.
There's another question. Is there any difference in doing a TUR immediately after acute retention or after 2 weeks once the inflammation is settled?
That point is absolutely true, I think, because whenever there is a majority of the times the retention is basically because of an infarct inside the prostate, and that produces a significant hypervascularity initially, which settles for a period of time. If you have done a resection immediately after day 1 after retention, you'll have a little more bleeding, whereas when you do a resection after 15 days on a catheter, it may be a different thing. One small point which I always say for juniors was whenever there is a perforation like that, don't try to resect the tissue around the perforation. Most of the time there is an extravasation which lifts the tissue there and falsely looks as if there is some adenoma. So leave some adenoma even if it is there around the perforation. That will be better off rather than trying to flatten the whole thing and make it look good. What do you say, sir?
No, I agree with you because what you are seeing is in magnification. And
Yes.
moment you put your catheter, it will collapse.
Can I take the permission of Dr. Gupta and Deepak Kirpekar that I've got some urgent work to attend to?
Okay.
Most
And,
welcome.
Thank you for
permission
being
of-
with us.
Thank you.
Permission
Dr.
of
Keshav.
the ISU chairman Harun Chawla and Dr. Mallikarjun.
Thank you, sir. Thank you, Dr. Keshav, for being there with us. Thank you.
Mali, thank you.
Thank you.
Good.
Thank you, Keshav. I thought you will be there another for 15 minutes.
Hello.
Mallikarjun, are you going to have another case or no?
Sir, I don't know, Arun. There is
after this we are having a very interesting talk that is on continence in TRP. That is will be given by Dr. Malik. After that, we'll take a call. Means our plan was to have around 12:15 to wind up. We'll take a call after that because we want to listen to him. This is a very excellent talk.
So we can listen to the talk now.
Yeah.
Yes, sir. I think we can listen to the talk and see Dr. Taif at the end once he finishes the thing.
Or PIP.
PIP will be there continuously. It will be there.
Get him admitted tomorrow morning. Don't worry.
Adi PIP, not talk main. I think Arun, there might be some questions on the chat, but you can look into it. But anyway,
Mr. Keshav has finished all, but I'll just inform Dr. Deepak and Dr. Gupta to keep a
Chat
just
on
on
that.
on the chat section. I am looking at that also. Okay.
Okay, then I'll be finishing this talk in the next 15 minutes maximum, and then we can look at what Taif has done at the end after dissecting the whole thing. So the talk for the beginners or the learners of TURP, urinary incontinence and prostate surgery. If you look at physiology of continence, what we thought about is going to be a internal sphincter which is there at the bladder neck and an external sphincter which is there at the verumontanum. This is what we thought about, and we majority of us still accept the same concept. Do you think either one is enough for a passive continence? Suppose we take out the active sphincter, the internal sphincter, external sphincter alone is adequate. Yes, we say that it is adequate. But what is needed for active continence? Active means, passive means at rest, and active means even at strain or anything. Let us get into the detail of it later. Clinical questions. If external urethral sphincter is enough for active continence, how to explain post-TUR continence? Because at any point of time, the external sphincter, which is outside the mucosa or outside the wall of the urethra, is never injured by TURP. Why resection beyond Veru leads to incontinence then? If the external sphincter also is not injured, how come the beyond resection will lead to incontinence? Why passive is absent but active is present in some cases? You do a resection, you come up, you get the patient back again, and you ask them to hold. He'll be able to hold and the urine doesn't leak, but he doesn't hold, it leaks. But why it is happening? Why stress incontinence is not there after transpubic erythroplasty? If external urinary sphincter, which is there in the membranous urethral level, is the reason for preventing stress incontinence, we have done a transpubic erythroplasty, but the patient is still continent and there is no stress incontinence. So what are the reasons for incontinence? Let us get into it. If you look at the sphincter anatomy, we all know if you look at this area alone, there is an external urethral sphincter which gets into the median raphe area, which we clearly see during our radical prostatectomy, and an internal lissosphincter of a longitudinal and circular fibers around the blue urethral mucosa. So this is external sphincter. And a pubourethralis muscle which forms a hook and causes is necessary for active continence. And the same thing which is depicted from a lateral aspect, and this is in relation to the radical prostatectomy, wherein all the nerves are there between the external urethral sphincter and the pubourethralis muscle sling. All these external nerves which go to the levator ani muscle are there. So if you look at sphincters of urethra, it is an inner lissosphincter or a smooth muscle sphincter, cylinder around the urethra, which goes right from the bladder neck area down to perineal membrane, and it goes into a little proximal bulb. So the whole area is active, and this whole area is essential for continence. At the same time, the rhabdosphincter is mostly around the membranous urethra and to certain extent onto the apex of the prostate, called external urethral sphincter apron, the US apron, which is seen in a radical prostatectomy, which we'll see. So this is the sphincters of urethra. If you look at urethral anatomy from outside, the inside part which we always look when we are doing a TURP, external urethral anatomy during a radical prostatectomy, if you look at, this is what you saw is a pubourethralis muscle. This is external urethral sphincters, this is the Muller ligament which is being divided, and what you see under the deep venous complex is nothing but the EUS, that is external urethral sphincter complex. See this? This is the inner smooth muscle layers, and this is the US apron which is there all around. If you divide, and if you have divided this during radical prostatectomy, if you divide this, I fast forward it, and that is the inner smooth muscle lining around the urethra, which is being divided now, which is seen as a urethra. And once you divide it, the wall of the urethra is divided, you will see the US apron, that is the rhabdomyosphincter, getting attached to the median raphe. That once you divide, you see the rhabdosphincter, which is attached to the median raphe. So this is the anatomy of sphincter from outside, which we all know when we started doing radical prostatectomy. So what is the sphincter function? If you look at the lissosphincter, which extends from the bladder neck down to the perineal membrane, it acts for the passive continence. That is what is contracting to prevent incontinence at rest. Active continence and voluntary interruption are by the rhabdosphincters and the pubourethralis and the pubourethralis muscles. Ejaculation, anyway, we are not discussing today. So what prevents incontinence is a mucosal coaptation at the level of in the urethra. Lysosphincter, intact lysosphincter of a sufficient length. In a normal person, it is from the bladder neck down to the perineal diaphragm. In a post-TUR scenario, it is from the verumentanum till the perineal diaphragm. Rhabdosphincter fast switch fibers to act during the times of active stress, and the levator ani as a backup. So these are the 4 components for preventing incontinence. If you look at a clinical situation, what we are seeing to the in a prostate and a urethra now, continence as rest is by the lysosphincter. In a post-TURP scenario, if you resect the prostate gland, which is seen here, the length between the verumentanum and the perineal diaphragm, this lysosphincter, which is just smooth muscle sphincter, that is SMS, which is just below the mucosa, the length of it is the thing which determines the continence, either passive continence, especially in these patients. And the rest of things is going to be determined by the skeletal sphincter, which is not going to be damaged in TURP, that is going to be damaged more in radical prostatectomy. So in a TURP, what matters is this lysosphincter length, which we will see at the end after resection of the thigh at this point of time. So what happens in active continence? If you look at this as a passive continence, what happens in an active continence? So passive continence is dependent upon the functional urethral length, which extends from the bladder neck down to the perineal diaphragm in a post-TURP scenario from the verumentanum till the perineal diaphragm. Whereas that is functional urethral length. What is active continence? Active continence is dependent upon these 2 muscles, what we are talking about. EUS, that is external urethral sphincter muscle, which wraps up around the membranous urethra, and the puborectalis muscle, which goes towards the pubic bones and it performs a U shape. So whenever there is active continence, means whenever there is a cough or a strain, the action of the US pulls the urethra towards the median raphe posteriorly, and the pubourethralis muscles pulls the urethra anteriorly. So that compressive nature of these 2 muscles will prevent incontinence during actively. That is when there is a cough or a sneeze or something like that. So that is very evident on a urodynamic studies. In a rest also, if you do a cystogram in a patient post-TURP, the whole thing will stop. The contrast will stop at the verumentanum, above the verumentanum. It doesn't descend at the level of verumentanum or below the verumentanum. It goes above the verumentanum. That means there is the internal sphincteric muscle which is contracting it, which is the reason for passive continence in these patients. So what happens in a large gland? Everybody talks about large gland. What happens is the length between the functional urethral length between the veru and the perineal diaphragm will come down because the large gland pushes the whole area. So even a small resection of the smooth muscle sphincter here which is compressed and from above downwards, which is going to have a significant loss of a sphincteric length. So the functional urethral length will become very, very short in a large gland. So this is the reason why when we talk about a large gland, why we should not resect much below the verumentanum, because to retain that length of functional urethral length between the verumentanum and the perineal diaphragm, which is longer in a short gland and a shorter in a large gland. So if you look at large gland, which you have been seeing now, there is an extension of the gland much beyond. And this is a perineal diaphragm. If you look at the length between the verumentanum and this is going to be shortened because the gland is extending right up to this area. So that is a large gland, how it looks like whenever it is extending beyond the verumentanum. So looking at what causes incontinence in TUR enucleation. So it is a lyso or a rhabdomyosal sphincter injury. Rhabdosphincter injury is very uncommon with TURP. It is a thermal or a resection injury of the lysosphincter, tear during acute angulation of the lysosphincter, mechanical stretch, especially during enucleation, which can damage the lysosphincter, which causes incontinence in the post-TUR scenario. Loss of mucosal integrity, which usually heals off very fast. So that is not a cause of incontinence for longer period of time. Bladder dysfunction with overactivity is a different situation, which we are not talking. We are talking about technical part only. So loss of lysosphincter. If you look at this resection, you see this. The resection has extended right up to the perineal diaphragm. You have resected the tissue much beyond the verumentanum and right up to this point, and the sphincteric length between this diaphragm and the edge of the mucosa is not even a half a centimeter. minimum requirement of length is around 1.5 centimeters, which is necessary. If you have a 1.5 centimeter length of mucosa intact between that area till the perineal diaphragm, the continence is definitely assured, which is not there in this case. This is what we are talking about. What has happened in this patient is this length has become very, very short, and this amount of lithosphincter has been resected on the right side. This was resected on the right side. Anterior commissure tear in patients who have a very high riding bladder neck, when you enter, the resectoscope completely tears the mucosa and even some amount of muscle. Most of these things do produce a transit incontinence, but they do heal and produces continence. This patient might have incontinence because the resection has happened much beyond the veru, right up to the pelvic diaphragmic area. So when you have this sort of an injury, incontinence may be quite certain, or if at all, if it doesn't, stress incontinence is significantly there. So types of incontinence, either total incontinence, exertional incontinence called CASIU, or a Brettusar or CADO is a different thing, which is not going to be discussed about. So rhabdosphincter, a striated muscle around the thing, which is mostly damaged in the radical prostatectomy. Lithosphincter, which is inside the mucosa, is the thing which is going to be damaged in enucleation and TURP. So how to prevent incontinence? Mucosal incision, adequate length of lithosphincter to be intact, deep enough to prevent a repeated sharing trauma by sheath, relatively more proximal at the roof compared to floor. This point everybody knows, because at the roof, the sphincter is a little more cephalad rather than caudal. Avoid thermal injury near the sphincter, which I was emphasizing. Perineal urethrotomy when acute angulation to enter the bladder. Mucosal incision in a TUR. This is a classic thing. If you have extended loops, look into it and come back, give some, have an assessment of the length, give an incision of the mucosa, from where up to which point you can resect. Have that mucosal incision beforehand so that you will not be extending much beyond that area. For all beginners, I think it's a good technique to do a safeguarding. Enucleation is another thing which I am not discussing now. Resection preserving lithosphincter. I've discussed about this. Whenever you're doing it, you scoop the loop and try to prevent or resection of that tissue which is below just next to the mucosa. So scoop it and make a boat shaped these things so that it doesn't excise the lithosphincter, and you still have a flap of mucosa with lithosphincter and the gland which is behind it, which is already resected. So at the end, you will see a nice evidence length of the thing which is existing right up to the verumontanum, even though the gland is behind. So that's a resection preserving lithosphincter. Perineal urethrotomy. The resectoscope is not reaching the bladder neck at all. Sometimes if you don't have that extended length resectoscopes, then you think about a perineal urethrotomy, wherein you pass an endoscope or a dilator on the urethra, and make a small incision on the perineum, get the dilator out. On a dilator, you pass a resectoscope directly into the bladder. So, but that way, you can do a resection. You don't need to close the urethra or anything like this. What all you need to do is just do a resection, complete the resection, and put a catheter through the urethra. On the second day or a third day, you take it out. It doesn't leak at all. We presume that it leaks through the perineum. It doesn't leak. Take it from me. In none of the cases, it leaked. So now you can complete the resection whenever the gland size is quite big. So perineal urethrotomy is one way. If you look at a SU, how does the scopy look in a stress urinary incontinence? This is how. So the length of the sphincter from the perineal diaphragm towards the verumontanum is very, very short. So this patient will have a stress urinary incontinence. This is how it looks like. In a total incontinence, you don't see any landmark. See this? You don't see the verumontanum. The whole thing is resected away, and this patient is totally incontinent. When you come out, you don't see any landmarks. The whole tissue is resected away. So this is a typical total incontinence patient which he comes in. So take-home messages are SUI after TUR and enucleation of a large prostate is common because you resect a little more smooth muscle sphincter than essential. Multiple components are the reason. Maintaining mucosal integrity for coaptation, functional urethral length between the verumontanum, or at the level of verumontanum to the perineal diaphragm of 1.5 centimeters at least. And bladder dysfunction might be a cause occasionally. Thank you very much.
Thank you, Malik. There's just a question in the chat box.
Yes, sir.
How to deal post-TURP incontinence?
Oh, that's first thing is not to create it.
Absolutely.
First thing is not to create it. Second thing is going to be managing is, as I said, I'll always say that we said normal practice that we always do some amount of perineal exercise, etc., etc., etc. If they don't recover in 3 months, the chance of their recovering is very less likely, because the damage there is going to be lysosphincter and the mucosa, not the external sphincter. So even if you do a significant amount of perineal exercises or whatever exercises what we give pelvic floor muscle training, the ability to get a control is going to be difficult. It helps only in a stress incontinence part, but not in a total incontinence part. And in our patients age group, in patients we have done 1 or 2 patients who had been managed with deflux injections under the mucosa by creating an obstruction there at that level, and rest of the patients underwent attempts post this thing. And we usually take a year's time anyway, that is not actually relevant for TURP, but it has been supposed to learn from what is that radical prostatectomy thing that you do wait for a year. If it doesn't recover, then we think about reconstructing after 1 year. This is how we learned after radical prostatectomy.
Yeah.
Any change of opinion, sir?
No, the second question was regarding the bulking agents, which you have already answered.
Deepak, can I say something?
Yes, please.
Yes,
Yeah, see, the initial perineal exercises have to be advised to the patient, and we have to ensure that they will do it properly, and they should contract the perineal muscles, not the knee only, with a pillow between the 2 thighs. That is one thing, and you can wait for some time, and 3 months is too short a time. I think so we have to wait minimum 6 months time, and some patients may become comfortable with 1 pad. If those who have got 3 or 4 pads, they are the candidate for the external devices, the springs or something like that. But those who have more than that and enough time has passed, then they need a sphincter. This is the only thing. Injection, deflux and all that we have tried, but it doesn't work much.
I totally endorse what Narmada just said. Absolutely correct.
Okay. Now,
Taif, are you ready to show?
There are some more questions in the chat box. I think so. We have already discussed this 24 and 26 spreadsheet. There is no need to discuss on this. Somebody has asked there, sir, suppose some patient metastatic prostate cancer on PUC, how much time after ADT give TWOC or go direct TURP channel? So Deepak, you like to answer or I'll answer?
Yeah, I think if he's on a catheter, we need to clear the channel, and I would go ahead with the channel TURP for him. At least his catheter can go off.
Yeah, I agree with you. You have to wait for 1 or 2 weeks because nobody wants to stay with the catheter for a long time. And if size of the prostate is larger, I think so better you can go for channeling TURP. There is no harm in that actually.
And I think I would take the opportunity to do the bilateral subcapsular orchidectomy at the same time, talking to the patient. He's already got a...
I agree with you 100%. If it is a metastatic cancer prostate, it will be more kinder to do a bilateral orchidectomy on it.
Yeah.
Now, which cutting loop best for TURP, thick or thin loop? I think so. We have discussed this. Again, it's surgeon's choice. And in storage, we have got this thin and thick loop, whereas Olympus, as but surgeon has already said, there is 1 loop only. So, it's a choice. You try both, see which gives you better result. My experience is thick loop should be used for prostate, and with slow cutting, it gives more hemostatic changes, and the loop life is also longer if you are using the thick loop. Functional urethral length 1.5. Bulking agent we have already discussed. I think so. We should not use it.
Taif, are you ready to explain?
Sorry?
Taif? No, I'm asking Taif to explain, sir. I think he is almost done with the resection.
Yeah, we can see it again. Go back and show us endoscopic vision.
Endoscopy. Take off. We're getting it, sir.
We are getting endoscopic.
Yes. endoscopy bada karo. All right.
Yeah, we are seeing it.
Let try talk.
In the external view, Malik,
Yes, sir.
Something is
external
hanging.
view, next to his receptoscope, I saw something else. What is it?
There's a gauze piece.
That's the gospice. Okay.
That's all.
Why he want to keep the gospels?
No, sir.
Leakage of.
I think, that was existing there. I think it got opened up. And that's all.
Okay.
How long has he been operating now?
Who's
Nearing 1.5 hours, sir.
All right. Are you concerned about the time that you spend in the urethra?
Resection time is 1.5 hours, or total time you are saying?
Sir?
It is resection time.
Resection time is around 90 minutes now.
90 minutes.
Are you concerned about how long you stay in the urethra, or you're not really interested?
If the urethra is capacious enough, it would not be a concern, sir. But yes, the shorter the duration, obviously better, sir.
Yeah. Well, you're dealing with a large gland,
Yes,
and
sir.
you've done an extremely good job. 90 minutes, 190 grams is not bad at all. Very good.
See, Deepak,
Yes.
Mallikarjun is there?
Yes, sir.
Yes.
Yeah. What about robotic simple prostatectomy for these gland, which is bigger than 150 gram or 200 gram? Why not to do that? Save your urethra.
I
You
know,
are so
sir.
much concerned with the urethra.
No, I don't deny that, sir. I don't deny that, but
No, that is our experience. We have done some cases, and
sir,
we found
we are in
post-operative. No
Hyderabad,
irrigation.
sir, not in Delhi market, sir.
No, it's not question of Delhi market. We have got cheaper version of the robot is also available.
X.
No. Last 2 days we had a very big meeting here of SSI, the Indian robot, and it was a multi-specialty conference. And we have seen now how the indications are changing and all that. So they say, why not to go to the 2-tier and 3-tier cities? It is more affordable to go for this cheaper Indian robot, actually.
So you're
And
talking
lot of
about
cases have been demonstrated, both cardiac and all that, in this conference. Sudhir Raval is a urologist who is guiding this company to make the changes and all that.
Is that mantra?
Mantra.
Yeah. But even Da Vinci has come up with a cheaper model, X.
That is furbished model, actually.
Yeah. They're selling it for 9 CR.
Anyway, that's a different topic of discussion. We will not discuss today.
Yeah.
No, but what I'm saying, if I get a large gland like this, and considering the post-operative and the operative morbidity and all that, I think so. There is no harm. Can afford. We should go for simple prostatectomy, robotic. And same job you do like your open enucleation of the prostate. And I'm surprised to see the literature from 2012 they are doing this procedure, and more than 3,000-4,000 cases have been done all over the world.
I think possibly in near future it will be the answer for many patients like this. I don't deny that fact. Taif, can you show? I think we're reaching 12 o'clock.
Yeah,
Taif,
you're reaching.
yeah.
One question by Prakash HS: subcapsular is better or total? I think so. It's always total orchidectomy. Subcapsular has the risk of leaving the testicular tissue there.
You can do epididymis sparing orchidectomy, which gives a patient a feeling of something still there instead of doing a total orchidectomy. But as far as consent is concerned, it has to be orchidectomy consent.
Taif, can you talk? Saif, can you show the thing behind from the perimeter?
I think that he can wash the bladder once and then he can
Yes,
wash
yes,
the
yes.
Yes.
two pieces are coming in the prostate.
Yes, sir.
Also, if someone can show the chips also in the container, sir, how much is come?
Yeah.
Some amount of tissue remaining behind. So I will have to clear out that, shave the prostate fossa and some
The
tissue.
shaving, what we discussed, the shaving of the residual
Yes, sir.
prostate.
So otherwise, bulk of the resection is all done. The last final shaving of the prostate and hemostasis is remaining. So I would not be dissecting further beyond this.
Dr. Gupta, there's a question. What about the 22 French TRP sheet? Your take on that, and if you have experience, can you share with us?
No, I use 26 French, and I do. If there is any doubt about the meatus, I do Otis ureterotomy, and I found that after using Otis ureterotomy, the incidence of this stricture is much less.
Otis
I
versus
also
dilatation
use
with the
I also
bougies,
use 26 French.
is okay. If Otis is not available, dilatation with the.
I also do a routine Otis ureterotomy.
And if I'm not able to put my resectoscope, I will put a caster, come out, wait 4 or 5 days, then go back and do it.
So, do you think that's an indication for using 22 French? Because we commonly use 22 French for, say, 45 to 50 gram prostates.
I don't have actually. I have no choice.
No, the loop size is small, so you take longer time using a smaller scope.
Yeah, this agreed, but you can just make it work for gland up to 45 to 50 milligram with 22 French because very comfortable. The movement excursion within the urethra is so smooth.
Actually, I don't have in my department, so I will now recommend them to buy 122 French resectoscope sheet.
There's a question from Anuj. The gland which is extending beyond Viru, can we resect it safely? He wants to know whether you need to shave it or how much depth he should go to prevent the continence also. Taif, if you can answer, and after that, Dr. Gupta and Dr. Kirpekar can add.
Sir, initially the first landmark that I showed was the junction of the adenoma and the mucosa. That is a landmark that has to be resected and enucleated out. So rather than shaving, we have been discussing that you need to scoop it out, preserving the mucosa with a shortcut, skipping the sheath steady. So this is what we have been doing. There is always compromised long-term results if the apical tissue is left behind. So you have to scoop it out, scoop out the adenoma instead of shaving it out. So, but yes, the overlying mucosa and the lysosphincter has to be preserved. So it has to be a scooping movement, but nevertheless a complete thing.
Lord Gupta, can you add something over there?
No, what he said is right. We have already discussed this point that we have to preserve the mucosa, resect the only adenoma by scooping in that area, and small cuts have to be made. There's no doubt about that. And mid up to the mid of the viru, I come. In this particular case, what he's doing, I think so, is still some tissue needs a resection from the apical area. Come out and see where is the viru, and you will appreciate that. See that. So this tissue has to come out. Yeah.
Another question is there, when you are doing a preparative imaging for this patient with alerts due to BEP, is there any role of doing truss or abdominal ultrasound imaging is okay?
I do only abdominal ultrasound in these cases. I don't have to do truss to see the size of the prostate and all that. Of course, the digital rectal examination will always be done.
I don't do truss for
PSA is IS10 in this particular case. Then I like to do a MP MRI to exclude the cancer of the prostate.
This
Uh,
man
well,
had a PSA of 10.9, but the pyrite score was 2.
yeah,
So it was
absolutely.
probably related to the large volume
The volume
of
of
a
the absolutely.
benign prostate.
Yeah. So Dr. Raghuveer wants to know, is there any role of reverse cutting near the apex?
But still, I think so. During the counseling of the patient, we have to tell him that your PSA is high. It may be possible that after TURP, some chips may be showing cancer prostate. Otherwise, they start fighting. Why you have done it?
That's exactly the reason why we did an MRI, sir.
Yeah, I agree with you 100%.
So Dr. Raghuveer wants to know,
If this
is it
pilot 3 or 4, I would like to do a biopsy before doing a TUR prostate.
okay.
No,
So
it,
Dr.
the
Raghuveer
plant
wants to
size
know,
was more than 150 grams. So I thought it is a volume related increase in the PSA.
Yeah.
That's the reason why we did an MRI. If the MRI is normal, that's the reason why we go ahead with the resection.
one question, reverse cutting at the apex.
No, I don't like to do any reverse cutting at the apex. What he's doing at the apex is the right way to do it.
No, but that is the, I make a reverse cutting because I identify where up to what level I have to come. And from there, one cut I make reverse. And that works very well in my hand.
Okay.
So that identify the site. I don't have to come forward cutting. I do backward cutting there.
Yes. Finish
Arvind? Arvind, are you there? Arvind Panda, are you there?
To see in the list, his name is there.
Tumor targeting is there, I'll do it.
वहां से बोला ना.
Taif has created a nice cavity and then a flap of
I think we are. Hello, sir.
Yeah, Taif.
Yeah.
Navneet, are you there? Allow Arvind?
Yes, sir. I am here, sir.
Yeah. Can you allow Arvind Panda to just have a screen sharing with a small talk on his
Dr. Panda, sir, was the co-host. I just saw him.
Okay, because he's telling he's not able to share. Just check
Sir,
it, just a small talk on instruments.
Sir, he has just logged off, it seems.
Okay, let me check.
He has logged off, it seems. There may be some issue with his local. Panda, sir, is the co-host, sir. He is connected with his video, but not his audio.
I'm just sharing
Dr.
screen.
Gupta
Yes.
and Dr. Kulkarni. Meanwhile, we'll be watching thanks to just the PIP finishing section. We'll just for the completion sake, we'll have a talk on instruments just for the sake of guidance. It's a short talk of around 7 to 10 minutes by Arvind Panda.
Sure, most welcome.
Sir, thank you so much. Thank you for the opportunity. I hope you can hear me.
Yes.
Yes, sir.
Let us have 1 minute, Arvind. Let us have the video operative the section being seen in the PIP. Just Navneet,
yes.
if you can show us the PIP, the operative part.
Hello?
Yeah.
Arun, I think once Arvind Panda shares, that PIP will not be there.
Okay.
So I can still see. I can still see PIP in the corner.
Okay.
Yeah, we are watching it.
Okay, Arvind, you can go ahead then. Arvind?
Arvind?
Good afternoon.
Arvind?
Arvind, share the screen. I think it disconnected.
We are back to the Endovision.
Yeah. If you can show the apical tissue, which has been in the flap of the lysosphere.
And clearing out whatever was minimal tissue is left behind at the apical region. And we should be done with the procedure with that. Hello?
Hello.
Arvind, please go ahead, Arvind.
We can see the first slide.
Yeah.
So now can you hear me, sir? Yeah.
Yeah. Please go ahead, Arvind.
The beginning of transurethral surgery started with the fulguration of bladder tumors. Started with the fulguration of bladder tumors, and just 1 second. So what happened here? So it was Beer in 1908 who first did that. And then the resectoscope was a logical conclusion of several inventions. One was a workable cystoscope by Maximilian Nitze. And then the electro tissue resection using cutting current. This was by an engineer called Reinhold Wappler, who was also instrument maker. Then the electrical cauterization using coagulating current by Beer and Bowie. And then the invention of the wire loop resecting electrode by Maximilian Stern. And again, the invention of the 4 oblique lens by Reinhold Wappler. So what happened is the transversal resection of prostate was based on the combination of Stern's resectoscope and then and by McCarthy's invention of the loop electrode. So firstly, what we need for resectoscope now is a telescope. This is a 4 oblique. By 4 oblique, it means it can be 0 degree, 12 degree, 25 degree, or 30 degree. Basically, it should be looking forward. The second thing which is necessary, of course, for instrumentation is the resectoscope sheath. Here I have shown you the parts of a modern resectoscope. There is on the top is the visual obturator. Below that is the blind obturator. Then there's the inner sheath and then the outer sheath. So if I'm going to break it down, that was the Olympus. This is the STARS. So if you have a continuous flow resectoscope, you have a 26 French-side outer sheath, the inflow and the outflow. Either you have a rotatable inner sheath, and then you have the working element, which may be active or passive. In this particular picture, is active working element, and it's monopolar. You can see there is only one attachment of the high-frequency cord. That's at the top. That's at the 12 o'clock position. The inner sheath typically has a ceramic beak. I will come to that later. It's the insulation. And then when we assemble the whole thing, this is what it looks like. All companies have a similar design. That was the first one was Olympus, second was STARS. This is the Wolf. All of them have a very, very similar design. So this is the Wolf 26 French, rotatable, continuous flow resectoscope with an active cutting monopolar working element. Now, if you break it down, what do you mean by continuous flow sheath? The continuous flow sheath was initially described by Iglesias in 1975. So it was also called the Iglesias system. There's an inflow channel through the inner sheath. So there's outflow channel between the inner and outer sheath. So if you look at these diagrams, so this is the outer sheath through which the outflow flows inside and it flows out. In between the outer and the inner sheath, the inflow of the water ingress is through the inner sheath, as we can see here. So it allows the resection to be done in an uninterrupted process. You can attach the suction to the outlet to make it even more effective. The problem is when it's the outflow holes must be in a large cavity for the outflow to occur. If it is sometimes inside a narrow prostatic urethra, sometimes the outflow doesn't work so well and we still have to keep emptying. But the concept is this: These holes, the irrigant flows out of these holes, and through this inner sheath, the irrigant comes into the bladder and into the prostatic urethra. So, okay. The obturator is of many types, but basically 3 different varieties have been described. One is the visual obturator. What you can see in the top picture, this is the Olympus visual obturator, and here this is a Strauss visual obturator. Then we have straight obturator, which is this one. You can see this one, the second picture is the straight visual obturator, and then you have the hinged obturator. Basically, there's a hinge in between the edge of the obturator, which has a very smooth end. So this can sort of hinge itself, and it can go up when the blood neck is high or when the median lobe is big. There is one more type of obturator, but I want to describe. This is the straight obturator, which is described by Lewis. This has a rubber at the tip, and this end can be rotated, opening and closing the rubber sleeve at the end. What it allows for, this Lewis obturator, is it makes a very smooth taper between the end of the obturator and the receptoscope sheath. So you can see this, the last picture here, how smooth the end is once the rubber has been opened, and the picture above where the rubber is not opened. If the end is so smooth, so there's less chance of urethral injury because of the smooth taper. Again, I would like to describe the visual obturator. It was first described and invented by a person named Schmitz. So it's also called the Schmitz obturator. And once we put the telescope inside, you can see that you can enter the urethra under direct visual control, and therefore there is less likelihood of urethral trauma. So for beginners and for most people, even I use the visual obturator all the time because I want to avoid urethral trauma at all times. It is very important because once we have urethral trauma, TURP can result in a stricture. Then coming to the inner sheath, which is found only in continuous flow sheaths, it has a rotatable tip. It is actually rotatable. The inner sheath is the thing which is actually rotatable. It has a tip insulation, and the inner sheath forms the vesicle end of the resectoscope. It has the tip is made up of a non-conducting material. Nowadays we are using usually it's ceramic. Earlier there were bakelite tips, but the problem with bakelite was extremely break. This ceramic tip is far more hardy. And the intermittent flow sheath, however, has no inner sheath. So the intermittent flow sheath, as you can see below, the outer sheath itself will have the ceramic non-conducting sheath. Working element can be of 2 types. It can be active, it can be passive. In this case, I have shown the picture of the active and passive bipolar working elements, but the concept is the same. The active, so let us go to this. So actually, if you really divide it, it will be 3 types of working elements, or so-called loop control mechanism. There's active, so-called Baumricker mechanism, passive Nesbitt mechanism, and the rack and pinion type. In the active working element, the spring extends the loop out of the sheath, and the cutting is achieved by the tension of the spring by manual retraction of the index finger. So it's finger cutting. In the resting position, the loop is extended out of the sheath. So that is what defines the active cutting working element. If we assemble it in the resting position, the loop will extend out of the sheath. So we have to be very careful when we're inserting it inside the urethra, making sure that we pull the working element spring into the sheath when we're going inside, so we don't cause injury. The passive one, that's a spring that retracts the cutting loop into the sheath. And the cutting is achieved by extending the loop out of the sheath by the pressure of the thumb. So this is thumb cutting. And the loop is inside the sheath in the resting position. So this is how it differentiates active and passive. The third type is quite rare. It's available, but it's extremely rare. This is the original Stern-McCarthy instrument where the rack and pinion type was used. So there's a lever there, and then as we move the lever, the loop moves in and out with that lever. So the next slide will show you that this is the original Stern-McCarthy resectoscope. So you have a rack and pinion loop control. You can see this black lever here. It is this black lever. This is the lever that is moved to move the loop. And as you move the loop moves. As move the lever, the loop moves in and out. This is quite rare. Still, it may be asked occasionally in examination. And you can see the original instrument had a very large, very long beak. Nowadays, the beaks are much smaller because when you have a very long beak, small prostates, they're very difficult to resect. And this is a passive working element. A passive working element, you can see the example. You can see that the hole, once we assemble it, it's going to stay inside the sheath. Finally, I would like to describe the bipolar working element. The bipolar working element are basically, if we divide it, there are 2 types. One is, of course, the true bipolar. The second is the quasi-bipolar. in the true bipolar working element, that is only present with stores and ACMI. The current goes back through the opposite loop or through an additional double loop. ACMI has a double loop. Stores has an opposite loop through which the neutral current through which the current goes out. Neutral, so-called neutral electrode. In a quasi bipolar, they don't have a second loop for the second loop or a sort of mechanism for the current to go back. Rather, they use the sheath. So the sheath is used as a pathway for the current to go out. So you can see Olympus and Wolf. They have quasi bipolar. The problem with actually quasi bipolar is we really do not know what is the effect of the current passing through the outer sheath and going just beside the urethra. We don't know whether it's going to cause long-term stricture or not going to cause long-term stricture. So you can see this Olympus working element. Here you have an active electrode right here. Just the wire is going to fit it here, and here this neutral sheath, the neutral electrode wire is going to be fitted in. So this is how it is. So okay, let's go to the next one. So then I come to the evacuators. There are three types of evacuators now that are currently available. One is the Eurovac vesicle evacuator from Boston Scientific. This is the most commonly used one. We have many copies available in the market. The Toomey syringe is used by many practitioners who are used to it. The advantage of a Toomey over the Eurovac or the classical helix evacuator, which you see on the right, is that the pressure that the Toomey syringe exerts, the suction force is far more, while the classical helix evacuator has a very, very mild suction force. With the classical helix evacuator, basically the chips fall inside this bulb, so they don't go back into the bladder. With the Eurovac, it's a very innovative design. You have small holes, so the chips really cannot go back, and it's very difficult for the chips to go back into the bladder. All of them do the same type of work, but we have to be very careful when you handle the Toomey, because the Toomey can slip and fall if you are not careful. So connector, all the different companies have different connectors. The Olympus has a different shape to its connector. The Wolf has a different shape to its connector. Stores has a different shape to its connector. They basically fit into their proprietary system. So when you have or you have a plastic connector which you can jam into any of these systems and still use it. So coming to the loop is made of tungsten. The standard loop, which is about 0.35 mm thick. The thin loop is 0.25, but nobody really buys the thin loop. The standard loop, after use for some time, becomes thin. The thin loop leads less current. Therefore, for a bladder tumor, better to use a thin loop. The thick loop, of course, people can buy for a TURP. It's about 0.4 mm thick. And then there are the ball electrodes and the colleague's knife, which is for a BNI. These are the things which are most commonly used in the TURP setup. Irrigation fluid, just for the sake of completion, ideal irrigation fluid is transparent, isotonic, non-conductive, non-hemolytic, non-metabolized, non-toxic, inexpensive. It does not exist. As of now, we don't have it. The two most common irrigation fluid are glycine, which we use in monopolar cutting. Of course, they can use the 5% dextrose and sorbitol also. It's a non-essential amino acid introduced in 1948, is hypoallergenic, is used at 1.5% concentration. At this concentration, it is actually hyposmolar. So, and of course, we can use normal saline for bipolar, and that can cause, if large volume absorption occurs, acetonic hyperhydration. It's not that it's without any side effect. Diathermy, for the sake of completion, again, it can be monopolar and it can be bipolar. Basically, it's high frequency current through a high frequency cable with a maximum power cutting up to 320 watts maximum. Earlier in the previous decade, or in 2-3 decades previously, the maximum power was 200 watts only. But the newer one, the ESG 400 of Olympus, can have up to 320 watts. And that makes for far better cutting. And it's far safer to cut with this sort of high frequency current. Why it is more safer? Because this is how it works. The frequency of alternating current, if you have low frequency alternating current, it's going to cause depolarization of nerves and muscles and cause twitching. But if you increase the frequency to a level that is very high, few kilohertz or megahertz, then the depolarization cannot occur because there is very little time for the depolarization to occur. So at that point of time, the transmitted current will cause a heating effect at the point of contact rather than depolarization. If the heating effect is significant and more than 100, then it will cut. If the heating effect is low and between 65 to 90 degrees, the protein becomes denatured and then it will coagulate. So the continuous waveforms are found in a cutting current. Intermittent waveforms are required for coagulation and are found in coagulating current. As long as we understand this, we should be okay. Bipolar resection does not use this principle. Here, high frequency power passes the saline irrigation system, and this high frequency power causes a vapor layer called plasma. And this contains energy charged particles which cause tissue disintegration through molecular dissociation. Once the cut is initiated, then the power reduces significantly to 90 to 120. But initial cutting requires very high power. And finally, for the sake of completion, again, we should know about the monopolar neutral plate. It should have wide area of current transfer, so it has minimal heat. It should be close to the area of surgery, preferably in the thigh, mid-calf, or below buttocks for transarterial surgery. The area where you're putting the monopolar neutral plate should be scareless, it should be hairless, no bony prominences, because then you have a point where current can arc. Full contact is necessary, no partial contact, because then it can cause burns. And there should not be any metal contact between the neutral plate and surgical field. As long as we follow these principles, we should be good, and there should not be any inadvertent burns when you are doing a TURP. Thank you so much. If any questions, I'll be willing to take it.
Thanks, Arvind.
Thank
I
you.
think very
Thank
nice.
you, Arvind. Yeah, good presentation, and you have told the basics. I think so. Any new resident or surgeon should know the nitty-gritty of these instruments, because in endoscopic surgery, instruments plays a very important role. Only you have not mentioned about the endovision cameras. Actually, you could have added little bit
So the
on
camera
that.
I could have added, yes, sir. I could have added the camera.
No, it's all right. Thank you very much.
Thank you, sir. Thanks a lot.
Arvind, can you, right.
Yes, sir.
We are there, sir. We are there with you.
Thank you. I think, Arun, you can have a last comments with Taif, and I think
Yeah,
he's finished his section.
Sir, Taif can show the whole fossa. He can show the chipset, and he can show us the time spent in the further section. And we'll take the comments from Taif, and then from our moderators, and then we'll wind up.
Yep. Taif, so this is the fossa at the end, sir. View from the Veru. Most of it is debulked. Some amount of few nodules are there which can be toileted off, shaved off. And this is the apical region. We have excavated sufficiently from here. Small tissues left behind. I can dissect out a couple of things here further. So otherwise, bulk of it is done. Coming back, this is the amount of lysosphincter segment which is saved. And this is the region of the sphincter. And almost 1.5 centimeters of lysosphincter section is saved even beyond the Veru, with complete excision of the apical region. So we'll just complete the hemostasis further, and the small nodules elevations which is there, will shave it off, and that should be the end of the procedure, sir. External picture. How much is the tissue? Can you show the chips? No, reverse check. So that is the resected focus. Yes, that's
right. Excellent, sir.
Right, reverse.
Dr. Malik, if you have any comments, then we'll go to the moderators for their comments.
I think thank you. I think I should thank USA and ISU for the opportunity to give it, and I hope that we could finish 2 cases in the given 3 hours time. Thank you very much, Arun, for the opportunity.
Yeah. And we'll go to Dr. Gupta first and Dr. Deepak Karpekar for their closing remarks, and then we'll sign off with thanks to you, sir. Dr. Gupta, over to you, sir.
Yeah, I think so. This is an excellent demonstration of 2 cases in which 2 different techniques have been shown of the resection of the prostate, and most of the points we have already discussed. I think so. The message is only that one has to understand the anatomy of the prostate. They should know the blood supply of the prostate. They should know the landmarks. Where is the capsule? Where is the Veru? Where is the bladder neck? And accurate resection has to be done. One should be slow, steady, and have a good hemostasis at the end, and ensure that there is no chips or something is left behind. I think so. With good instruments, with good endo vision camera, one can do a wonderful job. And according to me, this is the gold standard for the management of the enlargement of the benign enlargement of the prostate in man, and is going to stay. I recommend that all the postgraduates, they must learn this procedure over and above whatsoever they want to learn other things, but they must learn the QRP before they leave their institution. They should request their teachers to teach them a good QRP. Thank you very much.
Dr. Deepak?
Thank you, sir. And
Ma'am, I think Dr. Deepak.
Both of them have done a wonderful job. And again, stress that TUR is not going to go away anywhere. This is going to be a bread and butter for every urologist, and they must know how to do a good job. I must say, today's cases were both different, both done very nice manner. And this case is absolutely amazing. 190-gram prostate done so well with such a minimum bleeding. Congratulations to both the surgeons. And thank you once again, USI, for giving me this opportunity to moderate a subject which is most favorite to me. Thank you.
And Dr.
Hello.
Sujata?
yes, sir. Thank you very much. All three of the moderators did a wonderful job and kept the discussion lively. I don't think anybody who joined left the session. And of course, Saif is doing a wonderful job, such good resection. Very nice resection, Mallikarjun sir and Saif. And thanks, Arvind, for your input on the instruments. And I think that completed the entire session. And thanks, Chawla sir, for choosing this favorite topic of yours,
One more,
and which you
and
wanted to do for many times.
yeah,
Yes.
and icing on the cake was the talk by Dr. Malik on continence.
Yes, absolutely.
Yes, sir. And even NP Gupta sir very well showed
Comments.
us.
Yeah.
Yes.
Nice anatomical diagrams. Yeah. We can sign up.
Okay.
Okay.
Can we take leave?
Yes, sir.
Thank you very much.
Thank you.
Thank
We'll
you,
sign off.
everybody.
Thanks to Navneet and Kiran for being there, for providing all the logistics support. Thanks today.
Enjoyed the session. Thank you very much.
Even
Thank
at the
you,
end
sir.
of the session, we have 75 people logged on. And
So
during
we
the session,
crossed around 200 midway. We crossed around
during
200.
correct. But
Yeah.
even now, there are 75 still watching.
Yeah. Okay.
Very good. Thank you, everyone.
Thank you. Bye.
गले में से अंदर निकल
Hello. Hello.